Thank you. Thanks. Yeah, just now she wrote. Yeah.
Can you hear me?
So you can go live.
Shall we?
Yes, we are ready, sir.
Okay. Welcome, ladies and gentlemen. Today is a special day where we celebrate a tryst which our nation kept long time back. And we have a tryst today as well with the galaxy of the superstars of glaucoma firmament. My task is very simple. My task today is to introduce our moderators who are trailblazers in their own fields. We have today with us the president of the Kolkata Academy, Chandrima Paul. We have our secretary, Dr. Suraj Chakraborty, and we have Dr. Sumit Chaudhary, who is the member of our governing body. Dr. Chandrima Paul does not really need any introduction in the glaucoma field. She has been in exclusive glaucoma practice for the last 27, 28 years, and she is the director and the head of the glaucoma services of the BBI Foundation. Dr. Suraj Chakraborty, who's the youngest of amongst us, he is a trainee from Aravind Eye Hospital and now is a chief glaucoma consultant in our Priyambada Birla Glaucoma Aravind Eye Hospital. Sorry about that, Shirajit. And Dr. Sumit Chaudhary, an ardent cricketer in his earlier avatar. Now he is an eminent glaucoma specialist and surgeon for the last 3 decades, and he's running our Ranavir Mukherjee's dream project like his own child. So over to you, Chandrima. Thank you so much. Wish we have a great meeting today.
Thank you very much, Dr. Rajesh. Thank you for the lovely introduction. And I'll just share my screen. Open my PPT. So can you see my PPT?
Yes.
Yes.
Can you see?
Yes.
Okay, so we start this evening with a tribute to Dr. B. Sridhar Rao. Dr. B. Sridhar Rao has been associated with us, the Kolkata Academy and Kolkata itself for a very, very long time, because sir used to come to Kolkata twice a month at some point of time and then once a month. And every Calcuttan knows him, so to say. He's a household name in Kolkata. And this is a picture of him at the 28th Glaucoma Society conference at Trivandrum, where he delivered the Professor N.N. Sood oration. This is following the oration. Sir suddenly left us. I actually spoke to him 2 days before he passed away. And he was a past president of the Glaucoma Society of India. So we'll observe 1 minute silence in reflection and respect of Dr. B. Sridhar Rao, the great teacher, the legendary glaucomatologist, and the true gentleman. So we observe 1 minute of silence, please. So that's 1 minute over. And with that, I'll move on to introduction of the faculty. So I start with the opinion leaders. Nobody actually in today's webinar needs an introduction. Everybody is so very well known in their field, but it's customary to do so. So I'm just going ahead with it. He would be delivering a keynote address. Dr. S.R. Krishnadas is an ophthalmologist trained in glaucoma and serving in the Arvind Eye Care System for the past 3 decades. His areas of interest is patient care, teaching, and clinical research. He has co-authored publications and chapters in epidemiology, genetics, and clinical trials pertaining to glaucoma management. He is currently of the Aravind Group of Eye Hospitals as a senior consultant ophthalmologist in glaucoma. He is a past president of the GSI. A very warm welcome to you, sir. The next opinion leader this evening is a keynote address delivered by Dr. Vinay Nangia. Dr. Vinay Nangia trained at Shankara Nethralaya and then at Manchester University, where he obtained his FRCS. He then did a glaucoma fellowship at the Massachusetts Eye and Ear Infirmary. He was the chief investigator for the Central India Eye and Medical Study. He is currently director at the Suraj Eye Institute. He is the former president of the Glaucoma Society of India, and he has about 134 publications with more than 45 in the Lancet and other peer-reviewed journals. A very warm welcome, sir. Next, we move on to our faculty, starting with the diagnostics section. Dr. Madhu Bhadoria. Dr. Madhu Bhadoria, just a second. She's the director of the Regional Institute of Ophthalmology and the Chief Medical Officer, Sitapur Eye Hospital, actively involved in clinical practice, teaching undergraduates and postgraduates, and concurrent research and community service. A very warm welcome, ma'am. She would be speaking on how to suspect glaucoma during external examination at the slit lamp. Dr. Tanuj Dada, Professor of Ophthalmology, RP Center of Ophthalmic Sciences, AIIMS, New Delhi. He is the Secretary General of the International Society of Glaucoma Surgery, Chair of the Associate Advisory Board and Global Education Committee of the World Glaucoma Association, serves on the Board of Directors of the Asia Pacific Glaucoma Society, and as an expert on the Glaucoma Task Force of the International Council of Ophthalmology. A very warm welcome to you, sir. Sir would be speaking on gonioscopy for the clinician, which would be video assisted. Dr. Meenakshi Dhar, she is a well-known glaucoma specialist of Kerala with over 25 years of experience, currently serves as professor at the Department of Ophthalmology, School of Medicine, Kochi. A very warm welcome to you, ma'am. She would be speaking on new angles in imaging. Dr. Pranav Ranjan is a consultant and HOD at Renu Eye Center, Patna, and he is honorary secretary of the Eastern Zonal Ophthalmological Congress. A very warm welcome to you, sir. Dr. Rajul Parikh, ex-consultant of LVPI Institute, Hyderabad, has a large number of publications and authored many chapters in textbooks. He is the director of the Sriji Eye Clinic and Palak's Glaucoma Care Center, a high-tech, fully equipped, state-of-the-art tertiary glaucoma eye care center at Mumbai. A very warm welcome to you, Rajul. We go back a very long time together at the GSI. He would be speaking on determining structural progression. Next, we move on to Dr. R. Venkatesh. Dr. R. Venkatesh is a glaucoma specialist with special interest in environmental sustainable eye care. That indeed is so profound, your introduction. And thank you very much for joining us today. And he would be speaking on the new perimeter. Dr. Manish Shah. Dr. Manish Shah is one of the leading glaucoma specialists in private practice in Mumbai since last 22 years. He's a faculty member and past treasurer of the GSI. A very warm welcome, Dr. Manish Shah. And he would be speaking on 24 hours intraocular pressure. Dr. Gauri Murthy. Dr. Gauri Murthy is a senior consultant in glaucoma at the Prabha Eye Clinic and the VIIO. She has published studies in peer-reviewed journals and international journals. She also has been a faculty at the national and international glaucoma meetings. She has been the recipient of the Best Paper Award at the Glaucoma Society of India. A very warm welcome, Dr. Gauri, and she would be speaking on pitfalls of OCT. Dr. B. Shanta, she is the Director of Glaucoma Services, Shankara Nethralaya, Chennai. Thank you very much for joining us, Dr. Shanta, and she would be speaking on imaging in childhood glaucoma. Last but not the least, Dr. Shushma Tejwani is a head of the glaucoma services at Narayana Nethralaya 2, Bangalore. She has presented as faculty in many national and international meetings with several publications to her credit. She specializes in pediatric and complex glaucoma. She's pursuing her PhD in genomics and biomechanics of glaucoma. With this, we move on to the next section of the webinar, which are the diagnostic dilemmas. And the faculty for the diagnostic dilemmas, the case presenter here is Dr. Devang Angmo. Dr. Devang Angmo is an assistant professor of ophthalmology at the Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi. A very warm welcome to you, Dr. Devang. And she's going to speak on a case of ocular ischemic syndrome. The discussant for her case is none other than Dr. Vinita Ramani. Dr. Vinita Ramnani, HOD of Bansal Multispecialty Hospital, Bhopal, with keen interest in glaucoma, has 26 years of post-PG experience. The panelists for her case are Dr. Aparna Rao. Dr. Aparna Rao is the head of glaucoma services at the LVPI MTC campus, completed PhD in molecular biology in glaucoma from KIT, Bhubaneswar, is passionate towards amalgamation of basic and clinical research in clinical relevance to the patient. And the other panelist is Dr. Bhaskar Mukherjee. He's a consultant ophthalmologist and medical superintendent at the Dr. Nihar Munshi Eye Foundation, Kolkata. Very warm welcome to both of you. Next case presenter is Dr. Purvi Bhagat. Dr. Purvi Bhagat is an associate professor and head of glaucoma clinic, MNJ Western Regional Institute of Ophthalmology, Ahmedabad, Gujarat. A very warm welcome to you, Dr. Purvi. Discussant for the case is Dr. Sanjay Kumar Daulat Thakur. He's a fellow of the University of Wisconsin-Madison, USA, with 26 peer-reviewed publications, professor and HOD at Medinipur Medical College, and an examiner of the MBBS and MS courses in 13 universities across 9 states. A very warm welcome to you, Dr. Sanjay. This evening's panelist for Dr. Purvi's case is Dr. Ravi Kumar, Dr. Kumar Ravi Radha, and he is associated with BBI Foundation as a glaucoma and cataract consultant. He is a glaucoma fellow of the LV Prasad Eye Institute and was earlier associated with Shankara Nethralaya as a faculty member. A very warm welcome to you, Dr. Kumar Ravi. Dr. Shobhit Banerjee. Dr. Shobhit Banerjee, presently an associate professor in ophthalmology, Vivekananda Institute of Medical Sciences, and senior ophthalmic consultant at BBI Foundation, Nightingale Hospitals, North City Hospitals. He is a reviewer of the Indian Journal of Ophthalmology and has published many articles in peer-reviewed journals. A very warm welcome to you, Dr. Shobhit. Next, we have Dr. Sudipta Ghosh. Dr. Sudipta Ghosh would be presenting her case, missing the point. She is the HOD and consultant glaucoma and cataract services at the Rabindranath Tagore of International Institute, Kolkata, and she's an ex-fellow of the RVEEH and West Mid, Australia. A very warm welcome to you, Dr. Sudipta. The discussant for her case is Dr. Shuchandra Shaw, senior consultant glaucoma and comprehensive services at the Disha Eye Hospitals, Kolkata, and believes in contributing towards knowledge and sharing. Dr. Shuchandra has a very encouraging sentence for us. She says that every year I look forward to being an active participant of the very well organized KAO academic conference. Thank you, Dr. Shuchandra. You really inspire us. And thank you for being with us today. Next panelist is Dr. Thomas George. Dr. Thomas George is trained under Professor Ravi Thomas at the CMC Vellore and is an ex-associate professor of the CMC Vellore. He is presently a senior consultant glaucoma services at the Chaitanya Eye Hospital, Trivandrum. Thank you very much for joining us, Dr. George. Welcome to the webinar. Dr. Nilay Mojumdar. Dr. Nilay Mojumdar, currently heading the glaucoma department of Shushruta Eye Foundation, Kolkata, loves to paint the lives of glaucoma patients with hope. What a wonderful way to for your introduction. Thank you very much for joining us. And today's last case, but not the least in any way, would be presented by Dr. Vanita Pathak Ray. We go back a very long time, and Dr. Vanita Pathak Ray is the first Indian glaucoma specialist to perform minimally invasive glaucoma surgery in angle closure disease, phacoendocytoplasty. Currently senior consultant and cataract specialist at the Center for Sight, Hyderabad. Thank you very much, Dr. Vinita, for joining us today. Dr. Alokesh Ganguly. Dr. Alokesh Ganguly is a fellow anterior segment glaucoma and pediatric ophthalmology from the Aravind Eye Hospital, Coimbatore. He's a consultant at the Priyambada Birla Aravind Eye Hospital, Kolkata. A very warm welcome to you, Alokesh. The next panelist is Dr. Prashant Srivastava. Dr. Prashant Srivastava did a fellowship in glaucoma from Shankar Nethralaya and is an ex-consultant at Shankar Nethralaya. Presently, he is a consultant at the glaucoma service of BBI Foundation, Kolkata. Thank you very much, Prashant, for joining us this evening. And last but not the least, again, in no way, is our very favorite Dr. Partho Mondol, who is a senior consultant and glaucoma in charge at the Disha Eye Hospitals, Durgapur. Thank you very much for joining us today. So with that, I complete my introductions and I stop sharing immediately, and we can start with Dr. Krishnadas, his keynote address.
I just want to confirm if the slides are seen and I'm heard.
Yes, very clear, sir. Very clear.
Okay. Thank you, Chandrima and Sudipta and other senior faculty. The topic for keynote is high intraocular pressure is not primary open-angle glaucoma. And again, thank you, Chandrima, for this very stimulating topic. Okay. So yesterday it moved. Today it's not moving. Let me stop share and share again. Okay. So what is the importance of intraocular pressure in, say, diagnosis and management of glaucoma? We all know that intraocular pressure contributes to glaucomatous optic nerve damage, but nevertheless, elevated intraocular pressure is not definitive of glaucoma. And intraocular pressure is the single most causative risk factor. Again, intraocular pressure is unimportant for diagnosing glaucoma. Whereas clinical trials indicate that lowering intraocular pressure definitely delays progression of glaucoma and blindness, and optic nerve head or visual field changes rather than the absolute levels of intraocular pressure alone that determine treatment and in fact diagnosis. And it comes to that intraocular pressure is the only modifiable and treatable risk factor. Now, first hand is high intraocular pressure glaucoma. May not be, or maybe. If you see this bell-shaped curve, the distribution of intraocular pressure in the normal population, it's not a perfect bell curve, we all know. It's sort of a curve that is skewed to the right, where the intraocular pressures are higher, meaning many individuals with no glaucoma or in the normal population have intraocular pressures in the higher range, but without any characteristics of glaucoma. But if you see again the intraocular pressure levels in individuals with glaucoma, it's again widely variable from the normal teens to high intraocular pressures. So there is a proportion of individuals with glaucoma, probably a third to even half, who have normal intraocular pressure, but characteristics of glaucomatous disc damage of field level. So level of intraocular pressure by itself is a poor indicator of glaucoma. Now coming to the actual topic, intraocular pressure isn't primary open-angle glaucoma, then what is it? Some of the differential diagnoses. We know that primary open-angle glaucoma is a diagnosis of exclusion. We need to do a very careful evaluation of the entire eye, systemic evaluation, take a very careful history to exclude other possible causes of intraocular pressure, other possible causes of glaucoma, and then when there are no other factors that can contribute to intraocular pressure raise or glaucoma, then we say it is primary open-angle glaucoma. Nevertheless, it's the most common type of glaucoma seen in most of the world. Now, if it is not POAG, high intraocular pressures can represent ocular hypertension. It could be intermittent primary angle closure glaucoma, any of the secondary glaucomas, either open angle or angle closure. It could be uveitic, traumatic, drug-induced, probably steroid-induced elevations. It could be early neovascular glaucoma, open angle stage. It could be exfoliative or pigmentary. Strictly speaking, they are secondary glaucomas because there is a known cause, either exfoliation or pigments as a cause of resistance to aqueous outflow and IOP rise. And post intraocular surgery, especially vitreoretinal surgery, where one could present with very high intraocular pressures due to silicone oil induced raised pressures. Again, in the younger age group, juvenile and developmental, they are not strictly secondary glaucomas, but they could be primary developmental anomaly of the angle, which could present as very high intraocular pressures and could be a sort of a differential diagnosis in the younger age group for those with high intraocular pressures and glaucoma. Now, when we come to ocular hypertension, we refer to those with elevated intraocular pressure without structural or functional alterations. And as for primary open-angle glaucoma, a diagnosis of ocular hypertension again is one exclusion. We need to exclude the possibility of other causes of raised intraocular pressure, early cases of glaucoma, secondary or other causes, and when none exists and the intraocular pressure has risen without any changes due to glaucoma, then we refer to as ocular hypertension. Now, why is understanding ocular hypertension is important? Because we know that it is the leading risk factor for primary open-angle glaucoma, and ocular hypertension as a risk factor for progressive open-angle glaucoma is currently modifiable with appropriate management, and it does present as a window of opportunity to prevent visual impairment from progressive primary open-angle glaucoma. Very careful clinical history, both medical, ocular, that of general health and life expectancy is very crucial to manage ocular hypertension, and we need to exclude potential secondary causes like intraocular pressure raised due to uveitis, trauma, use of corticosteroids, as I mentioned earlier. And any family history of glaucoma blindness is definitely a contributory factor in diagnosing a risk factor or stratifying the risk factor in ocular hypertensives and deciding whether treatment is essentially indicated immediately or only observation is required. Now, when it comes to clinical evaluation, one needs to carefully evaluate for signs of exfoliation, pigmentation, inflammation, and trauma, and very crucial, gonioscopy to exclude subtle subacute or intermittent angle closure or other causes of raised intraocular pressure like pigmentation, peripheral anterior syndicate from past uveitis, which has now become quiescent, and trauma several decades back, which could cause angle recession and raised intraocular pressure or glaucoma several years later. And of course, narrow angles, which could be a reason for intermittent or subacute angle closure and raised intraocular pressure or glaucoma. Again, the importance of corneal thickness to assess, not only to assess risk of progression, but also thicker corneas may overestimate and thinner corneas may underestimate the intraocular pressure measured by most tonometers that are now clinically validated and available. A very careful clinical evaluation of the optic nerve bed, retinal nerve fiber layer, and documentation of the baseline optic disc and RNFL to detect any change in the near or in future, so that we'll be able to detect progressive changes and hence it could be indicative of glaucoma. And of course, a careful documentation of visual fields and RNFL quantitative evaluation by OCT. To your left, actually, this is a case of very high intraocular pressure presenting with a corneal edema, history of trauma. In fact, ultrasound revealed a vitreous hemorrhage, and it may not be very clear here, but there is a sort of a white deposits along the angle, something like a pseudo-hypopyon. This is due to settled ghost cells. So this is a case of ghost cell glaucoma. And this is an individual presenting with intermittent high pressures. Otherwise, the entire ocular evaluation is normal, including the optic nerves. On a very high magnification, we can see fine white keratic precipitates. So this is probably a case of Posner-Schlossman syndrome. Again, after dilatation, we can find exfoliation, and this is an individual with inverse hypopia. You can see the emulsified silicone oil here presenting with very high intraocular pressures. And these are obvious cases of iris new vessels, but sometimes very subtle new vascular glaucoma can present with very, very early new vessels, either in the pupillary margin or only in the angle. Many eyes with CRV occlusion can present only with the new vessels in the angle and not in the iris. So not only evaluation of the iris, the pupillary margin and a high magnification, but also careful gonioscopy is necessary to exclude early cases of neovascular. Again, a careful evaluation of the angle to exclude subtle signs like this is a very minimal angle recession. You can see this is marked angle recession 360 degrees, and this is an angle presenting with the cynical appositional angle closure, and very careful technique of gonioscopy is essential to diagnose narrow angles. For lack of time, I will not go into the details, and definitely we subsequently have a topic on gonioscopy to discuss the correct technique of gonioscopy that will not miss borderline narrow angles. So these are some of the differential diagnosis for raised intraocular pressure without glaucomatous damage. Now, when we come back to ocular hypertension, what is the risk of progression? Only about 1 to 2% of individuals with ocular hypertension do progress to primary open-angle glaucoma per year. But both the ocular hypertension treatment study and the European glaucoma prevention study have definitely proven that older age, thinner corneal thickness, larger cup-to-disc ratio, higher levels of intraocular pressure, higher pattern standard deviation on visual fields, larger cup-to-disc ratio asymmetry between either eyes, and even asymmetric intraocular pressure, a difference of more than 5 to 6 millimeter of mercury consistently between the two eyes could be risk factors for future progression of ocular hypertension to glaucoma. So, the eyes presenting with the ocular hypertension, but not definitive visual field changes or perceptible changes in the optic nerve head, we need to look very carefully. Looking at the disc on your right, definitely the vertical cup disc ratio is larger than to the one on the left, and very careful evaluation may even reveal subtle neuroretinal rim thinning or slope superiorly. And even inferiorly, the neuroretinal rim cannot be said to be perfect. You can see this large retinal vein bending here. So this is perhaps the margin of the cup, and this is definitely a large vertical cup disc ratio when present with the higher intraocular pressure. Definitely, this is a higher at risk of progression than the one you find the left. Again, compared to the one on the left, you can definitely see neuroretinal rim slope throughout. In fact, the cup margin extends up to here where the retinal vessel bends. So these subtle signs, when carefully looked for after pupillary dilatation and retinal nerve fiber layer, as we shall see later, if it is carefully evaluated in the retri evaluation, definitely many individuals with ocular hypertension will probably be diagnosed either as moderate to high risk of ocular hypertension, at risk of progression, or they may be diagnosed as early cases of primary open-angle glaucoma, where indeed quite aggressive treatment will be required to contain intraocular pressure and monitor pressure. This is very subtle retinal nerve fiber layer thinning seen in the red-free illumination, and you can see a flame hemorrhage here. This is an obvious case of flame hemorrhage. And you can also see associated retinal nerve fiber layer thinning along with the nerve fiber layer hemorrhage. These subtle signs, when these can be missed on cursory examination. It may look obvious here to all of us, but on a cursory examination, these subtle signs could be missed, and that's why we need to do a very detailed, dilated retinal evaluation to either detect, or if they are not there, at least document the baseline changes and seek for any change from baseline on a periodic basis to be able to detect those eyes at risk of progression to glaucoma at a much earlier stage. And of course, based on the ocular hypertension as well as the European glaucoma studies, the risk of conversion to open angle glaucoma is also based on the cumulative effects of both the central corneal thickness as well as the intraocular pressure level. So what this basically means is higher the central corneal thickness and lower the levels of intraocular pressure in an eye with the ocular hypertension, the risk of progression is lower, whereas thinner corneal thickness and those with the higher baseline intraocular pressures are at a higher risk of progression. Similarly, combining both the vertical cup disc ratio and corneal thickness also, one will be able to arrive at risk factors that can cumulatively tell us whether a particular eye or individual is at risk of progression to open angle glaucoma. And this is a public journal of ophthalmology based on both the ocular hypertension treatment study and the European glaucoma prevention study to be able to risk stratify individuals with ocular hypertension based on several baseline predictors like the age, the mean CCT intraocular pressure, CDR, all the risk factors we had mentioned earlier. We'll be able to arrive at stratifying the risk of individuals and then staging them either as low risk, moderate or high risk, and then decide whether they require treatment or just observation monitoring. So, of course, detecting progression, I'll not go into the details except that optic disc, RNFL photographs and evaluation by OCT and visual fields are necessary. And what is the benefit of early treatment in ocular hypertension is shown by this. Now, many of us feel that in ocular hypertension per se, without any change in the discs and nerve fiber layer or visual fields, they require just observation. Maybe this may be true for individuals with the low risk, but in individuals with the moderate to high risk, probably early intervention in terms of treatment to lower intraocular pressure is probably necessary. And this is shown in the follow-up study of the ocular hypertension treatment clinical trial group. Now, if you see here in the first 7 years, this is the dotted one is the observation group, and the one below is actually the treated group. For the first 7 years, if you see, the treated group, the progression seems to be very slow, and progression appears, the proportion of patients who have progressed in 7 years is much more significant in those with observed group. Now, at this point, both the groups were treated. Those on treatment were continued to receive treatment, and those on observation received treatment to lower the intraocular pressure. Now, you can see that the gap is broadening, meaning that if the treatment in those who are likely to progress, if the treatment is started late, the progression does not slow down. That is the lesson from this study and this plot. So in summary, high intraocular pressure is not open angle glaucoma, but is a significant risk factor for progression to open angle glaucoma. And as far as management of ocular hypertension is concerned, we need to critically identify those at high risk of progression. And as shown by the ocular hypertension treatment group, earlier treatment definitely delays progression in every individual with ocular hypertension. And those with moderate to high risk, definitely early treatment helps in delays progression, slow down progression to a significant extent. And this is not to say categorically or dogmatically that every ocular hypertensive need to treat it. The critical factor that we need to decide is which are the ocular hypertensives are likely to progress. What are the risk factors that the particular individual has, which are likely to indicate towards progression in the patient's own lifetime, and these individuals need to be definitely be treated. Well, if we feel that the ocular hypertensive individuals in question is low risk, what is required is very close periodical monitoring for both the structural and the functional changes, so that any change in either the optic disc, RNFL, or the visual field function can be detected earlier and appropriate treatment instituted, and any progression to visual impairment or blindness can definitely be delayed. So I'll stop there. Thank you very much for the opportunity. It was quite a very stimulating topic to think and prepare.
Thank you. Thank you very much, Dr. Krishnadas, and you did complete justice to it. Wonderful. There are questions for you, but we'll move on with the topics and then come back with the questions.
Sure.
So we move on to Dr. Vinay Nangia, sir, please. If
Yes,
you could share your screen.
Yes, I'll just do that actually. Can you see my screen?
Yes, sir, clear.
Am I sharing the PowerPoint as yet?
Yes, your PowerPoint is visible.
PowerPoint is seen?
Yes.
Okay, that's excellent. Okay. Good evening, everyone, and I'm going to take you through a short talk on the optic disc in glaucoma. The optic disc has been an important tissue for clinical examination. Over the years, it has helped in the clinical diagnosis and follow-up of glaucoma and enables us to plan treatment, set a target pressure, change medications, and also to decide upon glaucoma surgery. As we begin to use the OCT more for assessing and understanding the optic disc, that is, we're not only using it now to assess and understand the retinal nerve fiber layer and the ganglion cell layer, but also the optic disc, we hope to see if it will be even more helpful. So this is the normal disc that you see here. You can see that this disc is vertically oval. I'm not able to use the pointers. You just have to bear with me. And you can see the infrared image on the right side, and the infrared image is gaining more credibility now in assessment of the retina as well as the optic disc. And the red arrow takes you to the bend where all the retinal nerve fiber layers converge, and that is the neuroretinal rim, which you see as the pink on the optic disc. And then you have a yellow arrow, and that points to the margins of the optic nerve. And from the OCT, it becomes evident that the margin of the pink of the optic disc corresponds with the margin of the optic nerve behind the eye. The optic disc was found to be about 2.25 plus minus 0.51 millimeters square with a range of 1.12 to 4.61 millimeters square. And anything that's less than 1.23 millimeters square less may be considered to be a small disc, and something that is more than 3.27 may be considered as a large disc. This tells us that the size of the optic disc in a community also is influenced by the axial length, but that is another topic. The clinical importance of optic disc size is known from the fact that large discs have large cups and may be suspected to have glaucoma, and small discs have small cups and they may be missed to have glaucoma. And this is just a histogram that shows the distribution of the optic disc area in the first 1,000 subjects that we studied for this actually. So the size of the cup varies with the size of the disc. Large discs have large cups, and you can see the figures here. And small discs, so the disc on the left side, which is smallest, has got a small cup. The disc on the right side, which is largest, has got a large cup actually. So in small disc, the average vertical diameter may be considered to be less than 1.5 millimeter, and in large disc more than 2.2 millimeters, but this may vary in different regions. So here is a small disc on the left hand side, and you can see that you can barely see the cup, and you can see that there is a large cup in a large disc on the right side actually, but both are normal. The cup is the bare lamina cribrosa, which is filled with vitreous, but not so much with the neuroretinal rim tissue as the periphery of the lamina cribrosa is actually. The cup disc ratio varies in normals from 0 to 0.8. In reality, the cup disc ratio is determined by several parameters and is somewhat an inactive anatomic finding related to changes in the surrounding parameters in tissues. It is larger because the width of the optic disc and thereby the width of the optic nerve is larger, and enlarges because there is loss of neuroretinal rim tissue associated mostly with glaucoma actually. So the neuroretinal rim of the optic disc, this is the convergence and bend of the retinal nerve fiber layer, and what I say is what you see when you do a cross section and an enhanced depth imaging of the optic disc actually. On the left hand side, you have a disc that follows the classical isn't rule. That is, the inferior rim is broader or thicker than the superior rim, and then the nasal, and then the temporal. And on the right side, you can see that there is a disc that completely ignores the isn't rule, but is also completely normal. And you can see that the superior rim is bigger than the inferior, and the nasal rim also gives the impression of being equal to the superior rim and bigger than the inferior rim. So when the superior rim is bigger than the inferior, then we often term it at our hospital as the sin disc, because it is sinning against the isn't rule actually. You can see on the left hand side that the neuroretinal rim is almost lost except for minimal superior neuroretinal rim. And on the left hand side, you can see that this disc is absolutely normal. There was a lot of asymmetry in the glaucoma in this patient actually. A white appearance of the neuroretinal rim, or it's lost, the area of the neuroretinal rim is lost, is associated with loss of retinal nerve fiber layer. And I'm differentiating the retinal nerve fiber layer from the optic disc nerve fiber tissue, so that there is no light being reflected. Also, there is a sign of loss of optic nerve tissue, and also the vascular supply to the optic nerve is likely to have been affected in such patients actually. So what we see on the optic disc is often a reflection of what's going on not only in the retina but also in the optic nerve itself. Here is a patient where you see uniform enlargement of the cup in glaucoma, and that's also known to occur in addition to the notches and the segmental rim loss that we are so used to and are often so excited. But I think it is these eyes that often trouble us in terms of diagnosis. You know, sometimes you may just miss these eyes and say, well, you know, it's just a large cup, but it's not a large cup. Sometimes you do have uniform enlargement of the cup in glaucoma, and that's also quite possible. Here there is loss of neuroretinal rim tissue and there is bearing of the lamina cribrosa. There is significant cupping such that the Brooks membrane and the ring of white, is the tissue of Elschnig, now appear to form the margin of the disc temporally and inferiorly. So let's come to the parapapillary zones of the optic disc actually. Here is the classical beta zone in the region of parapapillary atrophy, and you can see chorioretinal atrophy and visibility of choroidal blood vessels and sclera, just mildly, not so much in the right eye, but much more in the left eye. And it's been studied, and we read so many papers and books where it's said that in eyes that progressed, the neuroretinal rim was significantly smaller and the beta zone was significantly larger. But this is now taking on a completely different meaning, and I'd just like to add the caveat that all decisions of the clinical diagnosis of beta zone and or gamma zone and other parapapillary changes are now completely dependent and relevant to OCT imaging and the axial length, which is that I'm just saying that you may not be able to actually make a diagnosis of a beta zone simply on the color photograph. So this is a slide that shows a right eye disc photo, and the patient has glaucoma. The refractive error is just -1 in the right eye. The red arrow shows a very small beta zone, and you have a yellow arrow that shows the gamma zone. There is hyperreflectivity of the scleral tissue where it meets up with the lamina cribrosa, and you can see that the yellow tip points towards a white line, and that is the tissue of Elschnig, and we are referring to that as the ring of white around the optic disc actually. And then we go to the optic disc hemorrhage. You can see the optic disc hemorrhage in the right eye inferotemporally, and disc hemorrhages may not generally subside because you have lowered the intraocular pressure further, because what we tend to do and what we have been taught is that we need to reduce the intraocular pressure even more, and studies have suggested that aggressive treatment has been shown to reduce glaucomatous loss. What constitutes aggressive treatment is something that you will have to decide for a patient, because if you have a patient who's on 2 or 3 medications and you achieve the target pressure of 13 or 14 and the patient gets recurrent disc hemorrhages that are not subsiding, then I think that you are going to be wondering as to what more aggressive treatment might you be able to give to this patient actually. This is a slide on the left hand side of classical retinal nerve fiber loss, and it's so vibrant to see that, and it tells you that a large area of the retina is covered by a small pinpoint area of the neuroretinal rim because all the fibers are converging at the point of neuro. So even a small amount of damage at the neuroretinal rim, leads to such a large wedge-shaped defect actually. But it's also important to understand that retinal nerve fibular loss is less commonly wedge-shaped, and it is more commonly you see generalized loss actually, because we suspect that wedge-shaped loss are a little bit like the retinal nerve fiber, the disc hemorrhages that you see, because the disc hemorrhages are considered to be relatively acute in the long process of glaucoma, and then you get a retinal nerve fibular defect, but that generalized loss is what normally takes place in glaucoma patients, and it is often hard to make out actually. So I think the optic disc will keep us thinking for quite some time to come and will continue to be a major focus of our research and clinical attention. Thank you all very much for having me share this talk with you.
Thank you very much, sir, for such a wonderful talk. I'm sure everybody enjoyed it and learned a lot from it. So we move on to the next speaker. And there are quite a few questions, so we'll take it once we finish off with the diagnostic part.
All right. Yeah.
So the next speaker is Dr. Madhu Bhadoria. Ma'am, you can share your screen. Sure.
So good evening, ladies and gentlemen, and I'll start right from the basic concept, that is how to suspect glaucoma on external examination and on slit lamp evaluation. So there is no limit to the power of human mind, and we really concentrated on point. It has a huge amount of significance. So to the beginning, we really need to have two very important prerequisites. One, a mindset that is looking for glaucoma, and second thing is the external examination and slit lamp biomicroscopic examination. So if we really have these two, we don't really need too much to add a comprehensive clinic, convert into a small glaucoma clinic. So when a patient walks in, we have to start looking from that point onwards. We look at his body, look at his tall, short, hand, spine, gait, look at his face. A blind look with an upper scleral show is characteristic of glaucoma blindness. Look at the surface, are there any hemangiomas or any kind of neurofibromatosis? We look at the file in hand. That will show to whom, how many doctors the patient has already been. His glasses, wearing myopes or hyperopes. And we look at the face, is he very anxious or is he depressed? Because all the drugs we'll prescribe will have an impact on this. So this young girl was sent to me with a glaucoma suspect only in one eye. And the diagnosis was written on her face. She had the right eye was involved. So when we look at, when the patient again walks in, we just look at these eyes. They have different kind of sizes of eyeballs and opacities. And many of them you can just diagnose by looking at it carefully. If a straight opacity is likely to be Peters, perhaps try to be a PCG, or if you see these entirely page always line, that is one of those diseases. We look at the type vessels, and when these gorgeous big vessels are visible, we don't think of anything else. First and foremost, it will be keratoconus fistula, or could be a superior vena cava syndrome, or sometimes maybe Sturge-Weber syndrome. A patient of thyroid ophthalmopathy will have congestion and these large vessels, but they will be very on the top of the insertion of the muscles, not generalized. There may be a certain amount of chemosis as well. So now coming to slit lamp. Conjunctiva is a holy grail for ophthalmologists of our kind, glaucoma people. Then we look at the cornea, AC depth, iris lens. The disc has already been covered by Dr. Nagia, and Tanuj will cover gonioscopy. So look at the first conjunctiva itself, because we are going to be truly using this for making any kind of glaucoma surgery. So is the surface healthy? Is it mobile? Where is it best? That will make us decide as to where do we make a bleb, or else what metabolite to use, should use or should not use. Like in a very thin conjunctiva, we will drop out the metabolite. If it's a thick conjunctiva, for sure we will use, and other decisions which are related to the surgery. Coming to another conjunctiva, if you look at this face looks absolutely normal, really, nothing looks wrong with him, a normal patient. But the moment you lift his lids and you see that two blebs sitting, so he is a young man operating for glaucoma already. Other than that, for blebs, slit lamp is the best equipment to assess in clinic. You can see overhanging blebs, one can see blebitis, a bleb which is fibrous become flattened, conjunctiva is retracted, or there is a wound leak, or it's a nice diffuse bleb or cystic bleb. So slit lamp is the tool which tells so much about the surgical success. When we look at this kind of episcleral vessels tortuous, the first thing in the mind comes, have I missed some kind of a hemangioma on the face? And the moment you look again, and there is a hemangioma, and same thing for the pigmentation, is it the nevus of the foeta? When we get a patient with corneas like this, the superior surfaces, the epithelium is totally unhealthy. This patient is likely to have been on loads and loads of drugs, four drugs at a time, with loads of preservative, or the patient has got a little questionable dry eye, or beta blockers are not suiting, they're making the eye dry. If there is a big huge bleb, just look underneath, there may be a Dellen sitting behind. Now we look at the corneal endothelium and the stroma. When we have this kind of a bullous sclerotopathy in a phakic eye, the eye is likely to have had an attack of acute angle closure, or maybe a long-standing raised IOP in a chronic angle closure. And if we see something like this, anterior plate should always line, and we see some corneal catators, that is nothing else but actually is an ice. We look at this here, and when we find a thick pigmented spindle, it's looking like a spindle. But the problem comes when we see catators along with the pigment. And these are the patients of fixed endothelial dystrophy and not pigmentary glaucomas. So coming to iris, when we see an atrophy like this at the rim, it happens in the patients of acute angle closure glaucoma because of the ischemic atrophy. But if there is a diffuse atrophy all along, then it is likely to be a chronic angle closure glaucoma. Then we can find these nodules, and when these nodules are there, the angles are not properly formed, and these patients of neurofibromatosis, at least 30% of them may have glaucoma. Coming to the iris has got a lot to tell us. So we look at the pupillary border, we can look for NBIs like this. We look here, we can see pseudoexfoliation. We can see a little more deeply, we may find the pupillary border of pseudoexfoliation. We look here at the sphincter, and there's a sphincter tear, so there's probably a history of trauma. And when we look at this beam, when the beam is like that, these are the iris cysts. And if there are multiple cysts 360 degrees, then this patient is likely to have the IOP rise. Then coming to presence of PI. If you see a nice looking PI like this, it's fine, but otherwise there may be fibrous PIs, or there may be multiple spots. The PIs have been tried or iridoplasty has been done, and these spots can be chosen for doing a PI because this is the place which is not likely to bleed, or we may see some of the complications of PI as this starburst kind of the cornea. Coming to iris curve, when we see a concave iris, convex iris with a shallow AC, it's most probably ACG, and we see pigment like this and a concave iris, then we must do a gonioscopy to rule out the pigmentary glaucoma. AC depth, von Herix, I don't need to tell this audience, but if the angle, if the von Herix is grade less, 2 or less, definitely a gonioscopy is required. Coming to infectious keratitis, lots and lots of these patients have very high IOPs. We see digitally only, but it's important to watch. And when hyphema is like this, there is no way that there would not be angle recession sitting behind it. So uveitis, if there is even slightest activity of the uveitis in a patient of uveitic glaucoma, then any trap we do will fail, or any surgery we do will fail. So therefore, that's very important to find. And when we find these iris bombays like this, if a PI is not done before the IOP rises, this PI doesn't really work because the eye is so inflamed. So the moment we see iris bombay like this, we should be doing a PI. Coming to anterior chamber could be housing loads and loads of cortical matter. It could be having malignant cells, especially in children. Could be having oil lines, or there could be ghost cells just in the anterior chamber. All these will be precursors to the glaucoma. So the exfoliation, we have pupillary border, we find something here, and look at the exfoliation defect on the slit lamp. So the exfoliation defects are literally at the border. Whereas if we have a pigmentary glaucoma, then these defects are likely to be epidermal. If we see pigmented nevi with a peduncle, then it is overreach syndrome, and if you have glaucoma, then it is most probably heterochromic iridocyclitis with a little raised IOP. And they give you a lot of clue. If its lens size, the microspherophakia here like this, leads to a good pupillary block and the glaucoma, the lens could be sitting actually anywhere. So if anteriorly subluxated, or it's gone back to the vitreous, either way is going to cause glaucoma. Or if somebody left a piece of nucleus or a piece of cortex in the vitreous, there is no way there will not be glaucoma. And then comes the lens thickness, if it's intermittent or mogaglian. Either way, this is going to compromise angle or phakomorphic glaucoma. And the patient is aphakic or pseudophakic. If the aphakia or pseudophakia is almost a license that the patient is most likely to have glaucoma. So with all these suspicions, I think we will not be missing too much. And with this, I'll say thank you, and thank you, Kolkata Academy, for inviting me here. It's been such a pleasure. Thanks a lot.
Dr. Chandramani, actually, you need to unmute.
Sorry, I just said that thank you very much, Dr. Madhu, and that was really inspirational because actually how much you can do at the slit lamp we could actually see from your talk. Thank you very much for being with us this evening, and Dr. Tanuj, you can please start your talk.
Okay. So thank you, Dr. Chandrima, and good evening to all. So in these 7 minutes, I'll be giving a brief introduction on what is the critical element of gonioscopy. And before I start, I have no financial disclosures, and all these videos I have collected, they are actually the hard work of the residents of RP Center, and I just want to express my heartfelt gratitude to two of my best residents who are both from Calcutta, Dr. Subroto Mandal and Dr. Ritu Gadia. They are the ones who helped me collect all the gonio photographs and the gonio videos which I'll be using in this presentation. So whenever you put a gonioscope in the patient's eye, you have to answer the following questions. Is the angle open or closed? And when I say angle open, the scleral spur should be visible. The next question is, does the iris touch the trabecular meshwork? If yes, what is the extent? And is there any evidence of previous contact between the iris and the trabecular meshwork that you find in the form of pigment, irregular pigment on the trabecular meshwork? Is the contact between the iris and the trabecular meshwork reversible? You have to identify whether it's a appositional or synechial angle closure. In addition, you comment on the amount of angle pigmentation, the configuration of the iris, any new vessels, any evidence of prominent iris processes, and of course you have to see through the trabeculectomy ostium. And now gonioscopy is also used for many therapeutic purposes like minimally invasive glaucoma surgery. Now before you do gonioscopy, you must do the procedure in a dark room with a very narrow slit that should not cross the pupil, otherwise you will get a pupillary constriction and artifactual opening of the angle. Now this is the most important slide of the presentation. This upper video shows a patient with open angle. So you follow up from the iris, you will see the ciliary body band visible, then a white zone is visible, that is the scleral spur. And beyond the scleral spur, you have this trabecular meshwork. So anytime you do gonioscopy and you can see the trabecular meshwork as well as the scleral spur, this denotes a completely open angle. Now contrast this with the video below. Here the only structure visible is the iris, and all these angle structures are occluded. That means the iris is occluding the drainage system or the trabecular meshwork. So the upper one is an open angle and the lower one is angle closure, and that is the basic use of gonioscopy to distinguish the mechanism of the glaucoma, whether it is an open angle mechanism or an angle closure mechanism. If you get this, then most of your work is done. Now this is a patient completely open angle, because follow from the iris, you can see this white zone, the scleral spur is visible, and beyond that the trabecular meshwork is visible. Then you have the non-pigmented part of trabecular meshwork and the short base line. So if the scleral spur and the trabecular meshwork is visible, that denotes that this patient has got a completely open angle. Another example, you follow up from the iris, you can see a small part of the ciliary body is visible, but this white zone, the scleral spur is visible, and then the trabecular meshwork. So it is a wide open angle, and this is a patient who has got an open angle type of glaucoma with the pigmentation of the trabecular meshwork. Now sometimes you will get a patient in which there is very dense uniform pigmentation of the trabecular meshwork, and especially in the superior angle. So whenever you get a patient with an open angle deep anterior chamber but this uniform broad pigment on the trabecular meshwork, this is a patient of pigment dispersion syndrome or pigmentary glaucoma. The pigment has completely obliterated the trabecular meshwork, and that is how you diagnose a pigment dispersion syndrome in this patient. And once the disease advances, now you can see the pigment has completely blocked the entire angle. None of the structures are visible. So this is an advanced case of pigmentary glaucoma where none of the angle structures are visible. And this is of course the slit lamp photograph of the same patient. You can see the trans illumination defects visible on the slit lamp biomicroscopy. All this pigment has gone in the trabecular meshwork. This is another patient. Here the pigment is there which is irregular, and if you see carefully, small white dandruff like material is present. This is called salt and pepper pigmentation of the angle. This is a hallmark of pseudo exfoliation. You can see this dandruff like deposits with the irregular pigmentation of the angle structure. So this is important to pick up pseudo exfoliation, because these patients are going to progress very fast and they have a much worse course as compared to open angle. Now coming to the other spectrum, here you see this is the trabecular meshwork, and the iris has come and attached to the trabecular meshwork. So this is called a peripheral anterior synechia or a goniosynechia. The iris is in contact with the trabecular meshwork. So this is a type of angle closure. You have a synechia formation. And just to make things clear, this is a patient, half the angle is open. You see the trabecular meshwork visible here very nicely, scleral spur visible, and the other half of the angle is closed. You can see the iris has now occluded the trabecular meshwork. So clearly left half an open angle and right half angle closure. You can clearly differentiate the two sides of the angle and distinguish the types of glaucoma. Now this is a patient coming with a high IOP, and this is why gonioscopy is very critical. You see here the scleral spur is visible in the center, but now you have the iris attaching to the trabecular meshwork. Secondly, you have these irregular pigments scattered all over the angle, including the trabecular meshwork. So you have this patchy synechia formation, the iris coming onto the trabecular meshwork. So this is a patient of primary angle closure who immediately requires a YAG laser iridotomy, and this is the most critical sign to pick up on gonioscopy, the iris touching the trabecular meshwork. Another patient, you can see the trabecular meshwork and patches of the iris sticking to the trabecular meshwork. So this is what we call synechia formation, classic sign of early angle closure, and immediately you have to do as an initial therapy either laser iridotomy, or that is not available, start the patient on pilocarpine till an iridotomy can be done. Now this is known as a Mount Fuji sign. This is a patient with a complete angle closure, and you have this mound in the iris, and if you see behind the iris, ciliary processes are visible. So this sign of a dome-shaped iris like a Mount Fuji sign is a sign of angle closure where is a thick anteriorly displaced lens causing a complete angle closure, and underlying you can see ciliary processes are visible. That is a sign of angle closure. And to make out the angle structures, you have to make a corneal wedge. So you make a 30-degree angulation on the slit lamp, two beams of light are visible, corneal epithelium, corneal endothelium. And where these beams meet, that point is the starting point of the angle, the termination of Descemet's membrane, or the Schwalbe's line. So whenever you do gonioscopy, you must do the corneal wedge test and identify where is the Schwalbe's line. Now, if your iris is present above this line, that means the angle is completely closed. Now, this is a patient, primary position, the angle appears completely closed, the iris is blocking trabecular meshwork. But when you do manipulation and move the lens towards the angle being viewed, you can see the white zone will become visible. So the serial spur has become visible. So this is Goldman type lens, manipulative gonioscopy. On primary position, angle appears closed, but when you manipulate, the angle opens up, the serial spur has become visible. And this is the indentation gonioscopy. Here you are using the Sussman type lens. You push the lens, press aqueous into the drainage channels, and then you will see this white zone of the serial spur appearing. So this is indentation gonioscopy. You can open up the angle, and this is used to distinguish between synechial or appositional angle closure. The most important part apart from angle closure is the proliferative diabetic retinopathy, or CRVO. This is a patient, you can see the arborization of new vessels on the trabecular meshwork. So this is a neovascularization of the anterior chamber angle. Anytime the vessels cross the serial spur, that is pathognomic of a new vessels in the angle. And this is very important to pick up. You must do undilated gonioscopy in patients of vascular occlusions and diabetic retinopathy to pick up these new vessels in the angle, and this patient immediately has to be referred for pan-retinal photocoagulation, otherwise the disease will progress to angle closure. So now a totally different pathology, an anterior insertion of the iris into the periphery of the cornea in an 18-year-old patient in both eyes. So this is an anterior segment dysgenesis, Axenfeld-Rieger syndrome, very anterior formation of adhesions between the periphery of the cornea and the iris in a patient who is otherwise got a very deep anterior chamber. So in 7 minutes, I have given you a brief overview of gonioscopy. If you want further details, this is our data from RP Center, which we compiled 2 atlases of gonioscopy. One is a text atlas, one is a video atlas. And this is our course available freely online from the World Glaucoma Association website, free to all participants. That gives a detail of all the gonioscopic videos and the techniques how to do. So thank you very much for your kind attention, and thank you, Dr. Chandrama, for this invitation.
Thank you very much, Dr. Tanuj. Those were indeed excellent videos, and I think the residents have hugely benefited from your talk and those videos. Thank you very much once again.
Thank you. Thank you.
We move on to the next speaker, Dr. Meenakshi Dhar. You can share your screen, Dr. Meenakshi.
A very good evening, and thanks Dr. Chandrama and the KAO for inviting me. It's a pleasure to be here. The angle anatomy plays a major role in the etiology and progression of angle closure glaucoma. Evaluation of glaucoma can be, the angle can be done by gonioscopy, as beautifully elucidated by Dr. Tanuj. It can also be done by the UVM, but I will be concentrating today on the anterior segment OCT. The disadvantages of gonioscopy is, although it is a gold standard, is that it is subjective. You require a lot of technical skill. It is not quantitative. It does not allow for the assessment of the structural volume. There is a significant variability in the assessment, either due to the varying annotation of the angle findings, or with different gonioscopic lenses, or with the different grading schemes. There is an alteration of the angle configuration by light, and it could also change because of the mechanical compression, which Dr. Tanuj had just shown, and also needs the patient's cooperation. The UVM, on the other hand, utilizes ultrasound waves, which has a lesser resolution and greater penetration. It has the advantage that you can visualize structures behind the iris, but it has the disadvantage that it is contact, dependent, needs of water bath immersion, longer image acquisition times, and may cause corneal aberration or infection. It can be not used in open globe or after surgery, needs again a skilled and experienced technician, and when iris falls back in a supine position, the angle changes, and there may be artificial widening due to the pressure on the globe. Although there has been a study which compared the UBM and ASOCT and found the two to be similar. Now, what does ASOCT do? It provides an excellent reproducibility and quality in their detection of angle anatomy, provides quantitative measurements of the angle, and an in-depth study into the relationship between angle anatomy and angle closure disease. It is non-invasive. It has an excellent high-resolution image. It is rapid, non-contact. It gives us cross-sectional tomographs of both the cornea and anterior chamber. It is objective and one can do a quantitative evaluation. It requires minimal experience for the image acquisition. It uses low coherence interferometry, and where initially it started off with using, the first one was used in 1994 by Dr. Izzat, where he had used 830 nanometers, but now while you have varying nanometers with the varying ASOCTs, and in times of COVID today, it will be a useful adjunct. There are, as the OCTs have gone from time domain to vector domain and now to swept sports, there are different anterior segment imaging systems, whether it is the Zeiss Visante or the SLOCT, which was on time dependent. Spectral is the Spectralis, or the swept source is the KC as the example. And as the lower wavelength leads to a greater resolution and with lesser depth penetration, one can also do the EDI with the spectral domain based ASOCT. And then Visante OCT is the one which has maximum, and in this you can have a vertical 10 mm linear scan, and there is large reproducibility of all the angles. The one which is wanting is the interior angle, because there is a dubious scleral spur identification there. The resolution is high, axial is 18 microns and lateral is 60 microns. The SLOCT takes a longer time to acquire the image, but it has a lower axial and transverse resolution. It requires manual rotation of the scanning beam. On the HDOCT also image adding the supplements gonioscopy there also. And then you have a swept source ASOCT. You can take a 360° circumferential image in with less than 3 seconds, and you can get a total panoramic view. The contact between the iris and angle structures anterior to the scleral spur is taken as an angle closure. The Visante has 6 modes of imaging, and various modes can provide different things, and you can image angles, and they usually move all together. So when we rotate, we get all 4 angles moving and changing. So how does one image? You recognize the scleral spur and you take the angle tool onto the side, and then the Visante then automatically calculates the measurements. There are multiple measurements which are taken, and you can analyze them either by the thickness calipers or by the angle tools or by the anterior chamber depth or width measurements. Of late, the biometrical analysis of the anterior chamber angle can be done with using the scleral spur as the reference point, and you have angle opening distance, angle recess area, trabecular. These are the major ones, but there are a whole lot of dimensions that one can get. The scleral spur identification may be difficult in a smaller AC depth, or in when there is a narrow angle, or in eyes with the shorter axial length, and in patients who are older. There are 3 techniques of identifying the scleral spur, and the one which gives the intersection of the ciliary muscle and the inner corneal margin is found least difference both inter and intra observer. Then when we go on, there is this beautiful article in IJO in 2015, which gives you all the different parameters. I will not go into each of these, but the ones which we normally use is the angle opening distance. Here you take the skull spur, take the 500 microns anterior, and you can drop the perpendicular, and this is what is called the AOD 500. And if you take it 750 INM from the microns from the skull spur, it becomes the 750 AOD 750. Then you have the trabecular iris space area, which is a trapezoidal area, which has the anteriorly the AOD, posteriorly the line drawn from the skull spur perpendicular to the plane of the iris, inner skull wall to the opposite iris. Superiorly you have the inner corneoscleral wall, and inferiorly you have the iris surface. Then you have the angle recess area, which is a triangular area, which is bound anteriorly by the ARA AOD 500 and posteriorly by the inner corneoscleral wall. Again, you have the trabecular iris contact length, which describes an anatomically closed angle. It is the linear distance of contact between the trabecular meshwork and the iris. Now, recently this ITC index has come, which is a software that can estimate the percentage of angle closure in a given eye once the skull spur has been manually identified. It estimates the degree of angle closure better than gonioscopy. With an OCT, AS-OCT, you can recognize the positional closure, and you can differentiate it from the peripheral anterior synechiae, and this can be very easily done. And this is the Cirrus HD OCT showing on the raster line and the angle closure. Here, the angle opening distance can be seen to enlarge after you have done a peripheral eyebrotomy, which can be used beautifully seen, and this can be helped to explain to the patient as to what is required. So apart from using it for the angle structures, you can also use it for pachymetry. You can also use it in an opaque cornea to find out whether there are peripheral anterior synechiae or not in a patient with a graft. It can also be used for research. It is a great patient education tool, and to convince the patient about what is the point in doing a prophylactic PI in a patient who's just having angle closure. It can also be used to visualize the trabeculectomy blebs and anterior segment implants. The newer AS-OCT parameters which have come, which have been associated with angle closure, have been a smaller AC width, area and volume, also the larger lens wall, a greater iris thickness, curvature and area. The iris volume is associated with angle width, and it is independent of the AC width depth. There is calculating the iris volume is possible with AS-OCT now, which is an important determinant of the anterior chamber angle. The AC area and volume and lens wall have been shown to have the most importance amongst these. So in nutshell, improved understanding of the anterior anatomic factors causing acute primary angle closure glaucoma attacks. One has found that there is a smaller AC depth and iris curvature, which helps us understand the anatomic factors, which is leading to an acute ACG attack. And it is also found that in these eyes, there is a greater lens vault as compared to the unaffected eye. In pupillary block glaucoma, the iris adopts a convex forward bowing appearance to its contour due to the pressure gradient between the anterior chamber and the posterior chamber. Also, there is an increase in the iris curvature, area and thickness, which has been shown to be independently associated with narrow angles. And this is the sometimes you feel that the LPI is patent, but it is not, and this can be discerned by the AS-OCT, and you can see that it is opened after doing giving another shot on the LPI. Recently, a longitudinal study has been done, which has shown that there is a widening, which was seen at 3 weeks, was later found to be less at 6 months, showing that there will be a non-pupillary block mechanisms which are also contributing. So a stepwise regression model with variables from these AS-OCT parameters has been shown to have a higher diagnostic capability in detecting patients with angle closure glaucoma. It can also be used in patients with keratoprosthesis where it is difficult to assess the angle. Also, it can be used to assess the blebs, and it can give the morphology and internal structure of the bleb. You can take a horizontal and a vertical scan. On ASOCT, the filtering blebs have a multi-layer, multiform bleb with a multiform bleb wall reflectivity with a low internal bleb reflectivity. They have numerous microcysts and a patent internal ostium, in contrast to a non-filtering bleb which has a low bleb wall thickness, small or absent internal fluid spaces, well-opposed scleral flap, and absence of visible root. So thus we can use them, and also we can use see the change with either a suture removal in the bleb or with after you give a 5-FU injection. So to conclude, imaging helps in diagnosis and planning management in glaucoma patients, especially the angle closure and the angle configuration. And it also be done in both the light mode and the dark conditions to visualize the angle. The limitation is the cost. It is not useful in plateau iris or phakomorphic glaucoma. Automated angle grading may be by software programs may be possible with the in future. And but we need to remember clinical examination cannot be substituted, especially the examination of the angle. So in a nutshell, angles in imaging do matter. Thank you very much for pleasant hearing.
Thank you very much, Dr. Meenakshi, for that really very informative talk. Thank you very much. And we move on to Dr. Venkatesh, Dr. R. Venkatesh, for the next talk.
Thank you, madam, for the kind opportunity. And I think this will be the kind of a very less expensive KOA meeting which you have conducted in the near past. So I think we are learning a lot from this COVID, and this is also a good learning. So I'm going to share you my experience on developing this new perimetry and why did we do this, how did we do this, and also the validation part of it. So basically, I don't have any financial interest. I helped a young graduate from Vellore Institute of Technology to develop this, and the journey was so pleasant. I'm going to share that journey. So we all know standard automated perimetry is gold standard because it's very essential for glaucoma diagnosis, not only for diagnosis but also for treating and also to monitor the progression. Many of the times we do multiple tests either to get a reliable baseline, or we need to do multiple times for follow-up because we need to give that care. And we all know from several studies, 85% of initially abnormal visual fields were normal on repeat testing, and it can be vice versa depending on patients' learning and also the mood and several other factors. So any innovation, I think this is the process which many of you would be familiar. You identify a problem, then you get an idea, then you design around it, and then you have prototypes, and then you have to run prototype after prototype, still you get an end product. So what is the problem here? I'm sure many of you have seen this happening. This is a screen, this is a shot from Madurai, which my good friend George had shared. We know that these field machines are so bulky, they are so tiring for our patients, and many of them, like this, somebody from semi-urban rural area is totally uncomfortable in doing this. So we wanted to do something. At the same time, we were seeing a lot of perimeter on tablets, like we did a trial for a Dell tablet based perimetry, and then we found that the perimetry was good even on a tablet or a screen, but still there are a lot of external disturbances when we were doing the field test at outreach campsites and also vision centers. Then we thought, why don't we design, and we got an idea that let's work with a virtual reality where we can cut off the external atmosphere, and so that the patient is focused on the VR part, and that is how this project started 3 years back. So the idea is again to take it to home. I'm sure at COVID times we are all thinking about taking several tests to home because we don't have anything to do telemedicine at this point of time. We can say hello to a patient, but we don't have an intraocular pressure or a visual field or a scan report to really talk to the patient from your hospital. So that is where I think we'll have to think out of the box to get some of these things outside. So this is called C3FA. Why C3FA? It is compact, comfortable, and also at this point of time it costs less than your gold standard, but we need to prove that it is also cost effective over a period of time. So the design was from 2015, and then the first prototype in 2017. We did a lot of preclinical trials, and then we did a demo in 2018 All India, where we had very good feedback from many of our colleagues, glaucoma people, general ophthalmologists, and that gave a little bit of good energy to even work better. And then we did collaborative trials. A team from Johns Hopkins, again David Friedman and some of his colleagues helped us to do the trial in the best possible way, so that this could also be commercialized, at least as a screening tool at this point of time. So these are the three components. When you say compact, the device is lightweight, it's easily portable, and you can do multiple patients conveniently. No, even when they are sitting in your clinic, you can do even when they are lying down. For example, neuro-ophthalmologists love this. In fact, the CFA which we have is with our neuro-ophthalmologists. So they do very comfortably for patients when they are lying down. Even after their tumors are removed, you can do. For somebody with a hemiplegia, you can do comfortably. And also this can be done in your vision centers and outreach activities if your hospital runs something like that. It's comfortable. Again, the posture, you can sit, you can lie down, you can do comfortably with less chance for fatigue. And also it costs much less when compared to the gold standard visual field analyzers. So the test duration, you can see here, roughly it is less than 5 minutes, I would say, to both the eyes. There is no positioning. You can do any position comfortably. It's kind of handy, it's portable, and also the cost, which you can see the comparison between some gold standard ones. And refractive correction up to a certain diopters, plus and minus 5, you don't have to correct. But beyond that, you may have to correct, and lenses are available now with the device to correct. You put the lens into the VR device, and that helps them to see clearly. If you see whether a technician should be there full time, need not be. If you have multiple CFAs also, a single technician can easily manage 2-3 machines at the same time. And finally, these are all some of the things which we definitely saw as a big advantage. And if you see, again, environmental distractions are much less with CFA. And if you need an eye patch for a HFA, you don't need that in a CFA, because one eye is automatically shut by the virtual reality when you're doing it with the other eye. Again, the validation part is questionable, and I'll share with you some of the results which we have done so far. These are some of the comparative reports which you see between HFA and CFA. When the defects are moderate to severe, you can see very good comparable results, something like this, where you see double arcuate or superior arcuate scotomas, and also patients with normal visual fields. So these are some of the results which we did, and it was published in Journal of Glaucoma very recently. So what we did was we included glaucoma people and the normal subjects. Both were in the same age group, more than 40, less than 70, best corrected better than 612, any type of glaucoma. They should have a reliable HFA test done before, and also willing to give a consent. And the normal subjects did not have glaucoma. We excluded anybody who had neurological pathology or who had disc suspects. Both the groups were randomized. They did HFA and CFA. They did first HFA, then CFA. And the controls also did in the same way. And we also did OCT and fundus photo for all these patients. And then we had a questionnaire to just find out how comfortable they were between the machines, whether they would do this in the future, whether they would be happy to do even at home in the future, things like that we asked. And then 2 masked glaucoma consultants made the final diagnosis. And then a data analysis was done. If you see the area under ROC curve, there was really a good sensitivity and specificity for moderate to advanced glaucoma. But when you took early glaucoma, it wasn't that good. So it's still not a very good tool for diagnosing mild or very early glaucomas. But when it was moderate to advanced, it had a very good sensitivity and specificity. Same way, the number of points missed on the CFA correlated reasonably well with mean deviation, but it was less strongly with pattern standard deviation. So at this point of time, we are not saying that it's a super equipment, but we are one step ahead in making it and refining it in a better one. So in this paper, what we found that was CFA produced less false positives than HFA, and it also detected true positives. And glaucoma subjects had a higher false negative rates than controls on CFA. When compared to HFA, CFA had higher fixation losses also. And it's not significant according to the recent study which we did. But the robust area under the ROC curve was very good for moderate to advanced glaucoma, but it needs more improved sensitivity to diagnose mild or early glaucoma. And high false positive predictive value for missed points to be glaucomatous is another thing which is worrying. And overall CFA is reliable based on false negative, false positive, fixation loss rates. But the point which we have to keep in mind is still it may not be a diagnostic tool, but it may be a good screening tool and also a tool which can be made into diagnostic with further refinement to this segment which we are focusing on. But the other interesting facts are CFA testing was quick when compared to HFA testing. Average was less than 4 minutes. And patients performing CFA were more comfortable than HFA, and 93% preferred a CFA over HFA. This is interesting. Now, whenever we ask this, they said, next time I'll do this. Now, I don't want to put my head inside the drum. So 60% stated that they would even are willing to do CFA for home testing. If somebody brings it to home or somebody sends it, we will be happy to do that. So this is how you can comfortably do this, you know, when the patient is lying down or sitting in your clinic. And this publication was well covered in media. And recently, have tried this in Africa and also in Salt Lake, where the Moran Eye Center, and they also had several presentations in RO, and they are publishing it. And they say that VR visual field testing can provide a practical and convenient means of screening for and monitoring glaucoma in settings where SAP is limited or unavailable at this point of time. But the future is bright. So again, something which you can do in this pandemic, because you can UV decontaminate. Our neuro-ophthalmologists are routinely using, our glaucoma patients, our glaucoma doctors are using for patients with significant damage before surgery to show them the fields and things like that. When you're not able to really do a HFA, you can definitely use this at this point of time. But newer strategies, we are working on fast threshold similar to CETA, and now CETA you have fast and faster segments, but still now we are trying to see at least the CETA fast, and we have been working on it, and the results are also ready, which is to be published. And we also have a big grant from DST, and almost $500,000 grant, 50 lakhs grant to take it forward to the next level, and there is a bright future for virtual reality as a perimeter. Thank you.
Thank you very much, Dr. Venkatesh. That was a great talk and a great invention. And I can see the chat box is full of appreciation for you. And it's, I think, just a matter of time until when we actually are going to look at how we are really going to redefine the functional use of diagnostic tools. So thank you very much once again. And with that, we move on to Dr. Rajul Parikh, please.
Okay, I'll share my slide.
Yes, please.
My slide are visible?
Yes, clear.
Yeah. So, good evening, everyone. Thanks, Dr. Chandrima and Kolkata Ophthalmic Association for inviting me. I'll be talking about the structural progression in clinical practice. Now we know this is the slide has been used left, right, and center for ages. So I'm not going to go about it, but we know that progression means evolution of disease from one stage to another, and glaucoma by definition is a chronic progressing optic neuropathy. The progression is a very important aspect in the glaucoma management. There are two ways we can do. One is functional, that is visual field progression, and one is structural progression. Now structural progression has lots of different parameters like planimetry, which is optic disc photography. We can also have different parameters, confocal scanning laser like HRT, then GDX and OCT. Now, since I don't have much time, I'll be talking only about the OCT progression, because in 7 minutes I cannot do justice to the whole structural progression. Now, the OCT progression, basically there are two parameters. One is event-based analysis and one is trend-based analysis. Now, most of the people are using Humphrey, and even somebody who is using Octopus. We know that there are the event-based and trend-based analysis is the common way of analyzing the progression in glaucoma, even if for the perimetry. So the same principle applies here for event-based and for the trend-based analysis. So just for the clearing the basics, the event-based analysis is where we have a two baseline field, ideally done within a short period of time, and those two baseline field act as we make a mean of it, and then the subsequent optic disc analysis or whatever the test we do, is compared to these two baseline to look for the progression. Now there are of course softwares available, but this is the event-based analysis. The advantage of event-based analysis is that we can pick up progression from the third test. Once you have a two baseline, the third test, if it progresses, then you can pick up the progression. Now event-based analysis has some limitation also, because measurement error do exist, and we have to have a certain amount of progression before we can pick up the progression on event-based analysis. So there is a limitation of event-based analysis. The second option we have is trend-based analysis. That means that we have a multiple test after the baseline. Those sequential tests are put on the regression map, and we do a plot the regression graph. And once they have a significant amount of the slope, then machine will label, the software will label as a significant deterioration. Now the regression analysis, the plus point is that it can pick up, they are more robust compared to the event-based analysis. They can pick up the change, the smaller change also. And if you look to OCT, then I'll be talking about more detail. But we have a average RNFL, we have a superior RNFL, we have an inferior RNFL, and we have an average coupling ratio. These are the four parameters the OCT, the serious OCT measures. Now it measures the rate of the change. So it not only deteriorates the progression, we also have an idea that how much the optic disc, the RNFL value is deteriorating per year. So you had a rate of progression idea, which will help us in deciding whether the patient is a slow progressor or fast progressor. The limitation of the regression trend-based analysis is that you have to have at least 6 to 7 fields before the statistical software can robustly analyze the progression or the rate of progression. So the small, if you have the first few fields or first few tests in OCT, the regression slope would not be the statistically significant even if the patient progresses significantly. So event-based analysis help us in early progression. For the long term, the trend-based analysis help us better. So these are the two base, the program software we have, and the two main differences between the event-based and trend-based analysis. Now, if you look the serious OCT, this is how the printout looks. You have a two baseline field, then the regression plot, and the different event-based analysis plot. Now, the most importantly, you have to know that it gives the yellow, that is possible loss. Now, the two subsequent tests shows the deterioration. The machine labels the possible loss. When three subsequent tests, consecutive tests labels its deterioration, the machine labels as likely loss, and there is a yellow possible increase. But we know that the possible increase in RNFL thickness is the in clinical practice is not possible, so I will not go about the possible increase. The possible increase is mainly the artifact which may have happened because of the inappropriate imaging or other parameters which I will be not talking. So the first is RNFL thickness map progression. This is event-based analysis. Now two baseline field is compared, the third test is compared with the two baseline, and the machine uses only 150 pixels, that is a 2% image area. It has a 95% specificity. Basically, it picks up the minimal loss. So this is a thickness map progression. The second is the thickness profile progression. Here, the segment they divide into 64 segments, and machine uses the 4 segment, the continuous segments. Basically, it uses around 7 to 8% of the area and look for the progression. So this is the second, the RNFL thickness profile progression. And the third is the trend regression analysis or trend-based analysis, where you have all these regression graphs. You have a average RNFL, you have a superior RNFL, you have inferior RNFL, and you have a average coupling ratio. So these are the regression analysis, and you can see it is slope, and it also write down the rate of the change with the statistical significance. Now, if you cannot see the statistical significance, the machine also changes the color of the dot. So once it changes from the black to the different color, that means that is a statistical significance. And here I have marked it here the inferior RNFL. There is a statistical significance deterioration in inferior RNFL parameter. So these are the way you can look the structural progression in the OCT. Of course, there are different machines available, but all the machine uses the similar principle. So you may have a different printout, but the principle behind the the software, the principle behind the printout is more or less similar. So this is how the printout looks, and you can say that this is to baseline. This shows the deterioration in inferior RNFL, which correlates in the regression analysis, significant progression here. So this patient inferior RNFL deterioration is significant, but the regression analysis starts showing the progression only from the 6 feet, which is bound to happen because regression cannot have, the plot will not be statistically significant till you have enough data that is at least 6 to 7 feet. Wherever event-based analysis will start showing the deterioration from the third test. So here the event-based is picked up earlier compared to the trend-based analysis, and you combine both parameters to look for the progression. So you combine event and trend both when you look for the progression. And it also gives this value. Now this value is important. Now here you can see that value is the yellow, that means 2 consecutive tests showing deterioration, and from here it's red, that is 3 consecutive tests showing progression, deterioration. So you can get fair idea that what is happening. It also is important because you must see the baseline value, and the baseline value, the 2 baseline values should be close to each other. It should not be a huge difference, because if you have huge difference in the 2 baseline value, that means patient has the values have changed, maybe because patient is deteriorated, progressed, or the scan quality is not good enough, and that has to be kept in mind. So when you select the 2 baseline tests, the value should be close to each other, and the scan quality of the scan should be very good, at least 7 or above. So if you have one scan, would be a different value, have a different value, and it's not good. So the scan quality should be good enough to include in your progression analysis. Now the GCC also same. GCC also is event-based analysis and the trend-based analysis. So the event-based analysis is the average thickness, and you can show here this is the 2 baseline, and the third test is compared with the 2 tests. And for the regression analysis, it is the average GCL plus IPL thickness and total inferior thickness. The same principle what I discussed earlier applies here also, and you can use both RNFL and GCC parameters to look for the progression. Now the 3 way you can pick up the progression in OCT. The one is widening of defect. You can see here that the defect is widening. It was a small defect, it's become bigger and bigger and bigger. That is widening of defect. One, the same way the perimetry. So the principle remains same. The field is increasing, the area is increasing. The second, the area doesn't increase, but the depth increases. So here you can see it was yellow, it become dark. So if you look the value, the numerical value, you will realize that the values are becoming much more thinner and thinner and thinner. That is deepening of defect. And third is development of new defect. You see here there was a defect here, small, then the new defect developed, and defect is now widened. So everything is happening step by step. You have a development of defect, then it widens and deepens. It can be either way around, but these 3 things you have to look when you look the OCT progression. Now, as I mentioned earlier, 2 baseline values should be close to each other. If your value varied to each other, then there is a problem, because then machine will not able to pick progression in event based and trend based also, because there will be lots of fluctuation and it will mask the progression. So now which parameter is important? Now if you look the advanced glaucoma study, intermittent imaging study, it shows that the focal loss volume both in GCC and RNFL is important. So only RNFL is not important, only GCC is not important. You have to look both parameters, and they are developing glaucoma composite progression index. It is basically like VFI, though it's not commercially available. It may be helpful in the long run to use that for the progression, like what we are doing in in perimetry using VFI. So I don't have much data, so I will not talk about it. The strategy is very straightforward. You have to look the entire printout, not 1 or 2 numbers. If you look 1 or 2 numbers, then you are bound to diagnose the red disease and green disease. You also correlate clinically with the optic disc. Look for the focal changes, not overall changes, and be sure account for the normal aging. Though the GPA program the statistical software takes care into the aging into account, but make sure that that has been taken care of. The optometrist has entered the patient's age properly. There can be various artifacts developed because of the improper data entry. So, and if you have the forum, which I have, then you can correlate the structure and function together and look for the progression in a much better way. Though I don't have much time, so I'll not go into detail. But to conclude, you have to look the optic disc progression. That means you look for the optic disc, the OCT imaging, look the overall, the quality of imaging is very important, the quality score. Of course, it has been other clinical parameters, and though my talk is only the structural progression, must remember that the visual field progression is very important. In fact, it is little more important than the structural progression at this point in time. So you correlate with your functional progression as well. So to conclude, the structural progression is very important. It may pick up little bit earlier than visual field progression, but do not rely only on the structural progression. And when you do look for the structural progression, don't rely on one parameter. Look the all printout. That means there are 3 different parameters which you have to look into it. Thank you.
Thank you, Dr. Raju. That was, as always, a wonderful presentation. Thank you very much. We move on to Dr. Pranav Ranjan. And after that would be Dr. Manish Shah, because Dr. Shushma Tejwani would be the last speaker. So, Dr. Pranav Ranjan, please, yes.
Thank you, Calcutta Academy and Dr. Chandrima for inviting me for this talk. Just 1 second. So, is perimetry enough to assess progression? This is going to be only text because this is a theoretical discussion. So, what is amiss in perimetry? And what I could find out is that in a standard white-to-white perimetry, the test points are 6 degrees apart. So most of the surface is based. So there is an insufficient information as mapping is incomplete. There is test variability and reliability is a concern. It's a subjective test, difficult for the elderly, diseased, and fatigued people. And sensitivity measurements are not direct, they are log converted. So what lies ahead? There's a wealth of information in these examinations, like the structural examination, which includes the neuroretinal limb examination, the RNFL, the ganglion cell complex, the ocular blood flow, contrast sensitivity, color vision, electrophysiology, and others. And we are going to discuss in brief all of them one by one. What is important in progression is that these 3 factors have to be considered: the current state of disease, life expectancy, and state at which the quality of life vision would be affected. There are several structural and functional methods to measure rate of progression. Visual field by standard automatic perimetry remains a gold standard, but imaging techniques like OCT are being qualitatively and quantitatively used to assess rate of structural change. As Dr. Rahul Parikh has already explained, that glaucoma progression is either event-based or a trend-based. It can be compared. So I'll not go into this, except that the event-based analysis is useful in determining the worsening, but fail to provide the velocity of vision. So therefore, a trend analysis will give you a view as to what is going to happen in future. Sensitivity change in a perimetry in approximately 13 to 17% of glaucoma patients progress at a speed of 1.5 decibel per year, and studies have found that the VFI changes by 5% in 15 to 20% of the cases. That would mean that these people in 20 years will become perimetrically blind. Some older studies also have estimated the same rate of blindness, which ranges between 6 and 13%. The structural measurements can be taken into account with the neuroretinal limb area, the RNFL measured by CSLO or OCT. Like visual field progression, this is also expressed linearly as change per year. However, relationship of functional and structural measurements are not linear. Both cannot progress at a constant rate over time simultaneously, though a true relationship between structure and function may well actually be linear. It is due to the fact that visual field sensitivity being log transform and is also dependent on other factors. The neuroretinal rim loss in glaucoma ranges between 0.018 to 0.0072 millimeter square per year. The RNF loss is 0.76 to 1.5 micron per year. These rate loss can be 3.7 and 4.6 times faster in progressing eyes, and faster rates are associated always with an increased risk of developing visual field damage. Another aspect is that of the ganglion cells, which includes the cell body, the dendrites, and the axons. And dendritic arbors are the first to be damaged, and ganglion cells and the inner plexiform layers are early predictors to glaucomatous damage along with the RNFL thickness. The loss in glaucomatous patient is nearly 10,000 ganglion cells per year. In glaucoma suspects, it is faster, showing visual field progression. It can go up to 18,000, whereas in stable patients, it is approximately 9,000 cells per year. GC analysis with OCT corroborates well with the circumpapillary retinal nerve fiber thickness. Combining both provides a better biomarker for glaucoma management. RNFL covers all the axons of the ganglion cell distributed in the entire retina. It is an indirect measure of the ganglion cell damage. Ganglion cell inner plexiform layer includes ganglion cell layer and the inner plexiform layer. The normal average GCIPL is 68 to 101 micron. The ganglion cell complex includes macular RNFL on top of the ganglion cell inner plexiform layer. The normal average thickness is 76.6 to 119.9 micrometers. But in glaucomatous side, it can go down to 53.6 to 99.1. And studies have investigated that the GCC and the GCIPL performance in glaucoma assessment compares well with the circumpapillary RNFL thickness. Both are equally effective for diagnosing and assessing progression. Some studies combine ganglion cell analysis with circumpapillary RNFL and optic disc analysis. Combining all of them improves glaucoma assessment performance more than using them separately, even in assessing progression of glaucoma. Macular region has around 50% of retinal ganglion cells. It is the primary location of glaucomatous damage in early stage. Circumpapillary RNFL covers the entire retinal ganglion axis. So current ganglion cell analysis ignores around 50% of the RCGs outside macular region. So this is the strategy's major weakness. One of the indicators for progression is optic disc hemorrhage, which has threefold increase in progression. The pseudo exfoliation, which can give rise to 2 times higher progression. The other factors can be a beta zone peripapillary atrophy and a lower blood pressure, which can have 42% increase in risk of glaucoma progression. Contrast sensitivity is another factor. It can be an adjunct to perimetry, and research shows that it is sensitive to early vision loss. It can track treatment efficiency. I'll just skip those slides. This is important that this is done by CSV 1000E test, which is an accurate measure of central contrast sensitivity. 70% of the ganglions cells are in the central 5 to 6 degrees. Studies show that central contrast sensitivity change occur faster than peripheral changes as measured by perimetry. And long time frame needed for perimetry to detect changes is a concern. The patient test time is just 2 minutes, and with this, compliance of glaucoma medication can be assessed. Another factor is the color vision, which changes with glaucoma patient, and most of the time the blue and yellow band is the one to be affected first. Electrophysiology is another important aspect which can come into play for detecting progression, because the ganglion cells die off in a very early stage, and clinical evidence show that there is a window to detect retinal ganglion abnormalities via pattern electroretinogram testing with the cells when the cells are still alive. Possible early intervention may slow or abate apoptosis. Studies demonstrate that the PERG signals corroborates with the activity of the retinal ganglion cells, and that loss of PERG signal is consistent with injury to the optic nerve. Furthermore, electrical abnormalities are detectable on pattern electroretinogram tests prior to RCG death. Beniet et al. Inferred that pattern electroretinogram signal is reduced by almost 10% 8 years before there is a change in RNFL thickness. So pattern electroretinogram test represents a powerful tool to start early therapy to avoid vision loss from glaucoma progression. And here I must also add to the fact that in pre-perimetric stage, if you can pick up the early changes because of PERG and the progression, we can have this tool as a strong tool to initiate therapy so that we can stop the progression. Thank you so much for giving me the opportunity.
Thank you very much, Dr. Pranav. Wonderful talk. So we move on to Dr. Manisha. Is Shushma there? No, Dr. Manisha. Yeah. Sir, can you stop sharing your screen, please?
Thank you, Dr. Chandrima, for your invitation, and Calcutta Academy for organizing such a wonderful meeting. It is really a great pleasure to be part of this. And I would be talking today on the 24 hours importance of 24 hours IOP in glaucoma. As we all know, glaucoma is a disease for which the treatment has the only IOP as the modifiable risk factor, and all our treatments are aimed towards reduction of intraocular pressure. But there is a big limitation. We do not have an ideal method to estimate the intraocular pressure. We are all having only estimations, and especially for continuous measurements. All the diurnal tests we are doing are one-time measurements spread out throughout the day. We are not having any system of a continuous measurement. There is a technique by the contact lens which can be put in. It's called triggerfish. This is only able to register the variations in the corneal contour as a measure of the variations in intraocular pressure. So that is the closest we have got to continuous IOP measurement. And single measurements, as you know very well, are affected by several factors such as the posture, whether it is sitting or sleeping, and we'll come back to this again. Aerobic activity, if the patient has just had a run or a swim, they'll get a lower pressure. Food intake, especially the fatty foods, have a higher, they raise the pressure. Water excessive intake, we know very well what impact it has. Also is alcohol and cannabinoids, and nowadays, people are using cannabinoids as very frequently, especially in the urban culture. You don't know who has taken what. Caffeine and tobacco are also known to raise the intraocular pressure. So when you are doing the test, you don't know what is playing a role. Besides that, you have umpteen local factors like tear film deficiencies, external factors like squeezing of the lids, tight lids, astigmatism, all these play a role. Now, this is a small study which was done on 32 patients, and they had the IOP fluctuations measured in the right and the left eye in two ways. They used, the first method they did was an office diurnal, where in only office hours, that is from 8 a.m. to 6 p.m., they have measured the pressures, and that is all shown in green. And the other way they have done is to measure it all 24 hours and seen this is the fluctuation in IOP which has been registered, and this is in the dark color. As you can see, in almost 80% of cases, the fluctuations measured in the full 24-hour cycle are far more in both the eyes as compared to what is measured only in the office. So that is one point I would like to make. And also, if you see a few cases here, will show you that the variation can be different between the two eyes. So this is case number 11, and you can see the fluctuation in the left eye was much higher during the 24-hour test. even this case number 3. So there is variation in between the eyes also, and definitely if you measure the pressure over a 24-hour period, you are going to get more data. Now, the most important question is to the clinician is, does these 24-hour fluctuations which we are observing, does it affect progression and does it have an impact on the final outcome of the treatment we are doing, or it is not? It is sometimes we are observing these changes, but they are not having a real impact on the long-term outcome to the optic nerve. Now, there have been many studies, some of which have been specifically designed to study the 24-hour fluctuation and the effect it has, and in some it was just studied by the way. So these are all the various studies, like the major ones are the CGITs also studied, the AGES also studied, and these are specific studies which were done only to look for 24-hour fluctuations. In the AGES, it was not diurnal fluctuations but long-term fluctuations where different pressures during different visits was compared. So what does all this make out? This is the famous study which was done by Asrani and which showed in home tonometry, when the fluctuations were more than 5 millimeters of mercury, the amount of progression they had was much higher than in patients who had a fluctuation less than 3 millimeters of mercury during the 24-hour period. And this is the AGES slide which shows patients with very advanced disease, and those who had much less progression had a fairly stable visual field over a 7-year period as compared to patients who had some amount of fluctuations, though their average pressures were more or less the same. So there is some evidence coming out of this, but there is a problem in really interpreting and implying what it means to us in our daily practice, because there is a lot of variations among studies in the definition of intraocular pressure, what fluctuation means, and standard deviation. Many factors affect the pressure transiently. So lack of proper longitudinal studies in evaluating the progression value of the 24-hour fluctuation is definitely there. This is a lack in our current scientific knowledge, because there is no reliable method of constant IOP measuring. So that is the limitation, because of which too many people have not been able to study this, and we don't know still whether it affects or it doesn't affect. But if you take a consensus, a majority of people do believe that in spite of all these uncertainties and inconsistencies, the short-term and long-term measurements of pressure are worth considering as potential risk factors for disease progression. So once we come to that, what are we treating actually? So now coming to the treatment. Now this is all the data which is coming out of the night lab which they have in California, and they have studied the intraocular pressure both in the day as well as in the night. And what we see over here is the chart, which is 3 charts. One is the green line, which is the normal variations. Then you have the second line, which is this one, which shows with timolol, and that very clearly shows that in the sitting position, timolol effect does not seem to be there at all during the night. Latanoprost in the night, in the sitting position, the pressure does go up a bit as compared to what you see in the day, but definitely from the baseline of normal patient, you do see some drop. So it is working partly. In the supine position, there is a similar graph, and you can see over here that in the sleeping position, there is some amount of change, and timolol does not seem to have any effect in that position as well. But latanoprost or prostaglandin analog group of drugs seem to work a little bit during the night time. Now coming to what we see, the same thing between timolol and latanoprost, as I explained to you earlier. In the sitting position, there is no effect of timolol, and no effect of timolol seen even in the sleeping position. So we know very well that timolol does not seem to work during the night time. What about brimonidine 0.1%, which is also sometimes used in conjunction with latanoprost? And we can see that the brimonidine seems to also have a similar graph to timolol, that in the night time the graph seems to completely overlap the untreated eyes graph. So it doesn't seem to be working either. Now what is happening to patients who are having brinzolamide or dorzolamide? In these cases, as you can see very well, again in certain places there is some amount, but again if you see, there is a complete overlap, that there is an overlap over here. So even the carbonic anhydrase inhibitors drops don't seem to be working during the night time. So you have a problem here that most of the drugs you are using are not effective during the night time. Now, except for the prostaglandin analogs. So there are some unanswered questions when we want to take this story of 24-hour IOP fluctuations into our clinical practice. The questions which we have in our mind is how many IOP measurements should be taken during that 24-hour or one day, and how frequently should the tonometry be performed on a patient who is on treatment over the year, and how much IOP difference is clinically important. If you get 3 points, 4 points, 6 points, what is the level of importance? So these are all unanswered questions as of today. But once you have a patient who has a very significant visual field defect and has a higher risk for vision loss over the next 4 or 5 years, you would definitely give importance to reducing the diurnal fluctuations. And how do we do that? We have to keep the drug therapy on a multi-drug therapy and include the prostaglandin so that you have some amount of reduction in the night. You can opt for additional laser treatment because laser patients are known to have lower fluctuations during the diurnal period, and definitely surgical interventions like a trabeculectomy is known to do very well in reducing diurnal fluctuations. So we have to keep these 3 points in mind in patients who are more advanced and having a higher risk. Also, in 24-hour IOP testing, if we accept the data that it is important to us clinically, is it possible for us to measure this in our day-to-day life or in our clinics? It is not possible for all practitioners to take in a patient and observe them over the full 24 hours, especially the night time, because the doctor himself is not able to take the pressures for in the night time, and even the residents, sometimes we don't have the facility to keep the residents in-house. So there are some other methods of having surrogates where you can try to make an estimate of what would be the 24-hour curve. So one method is to check the pressures in the supine position, because it is known to be seen that some patients do have a rise in pressure if they are made to lie down for 15 minutes or half an hour. The other way is the office diurnal, where you start during your office hours right from the first time you enter your office, keep the patient till let him be your last patient also, and keep measuring the pressures as maximum number of hours you can measure. The other way is a deferred diurnal, where you call the patient at different times of the day on different days. So that way patient is less inconvenienced, his working day is not disturbed, and you get somewhat an idea about the fluctuations also between days. There is some data to tell us that the water drinking test may be used as a surrogate for the 24-hour pressure monitoring, and there is a group of people who have taken this into study, and they have been able to show that 24-hour test can be used as a surrogate. So this group is from Dr. Ivan Goldberg in Australia, and they have done the study whether the intraocular pressure peak measured by the water drinking test reflects the peak which is measured by the circadian mode 24 hours. And also this group by Remo Susana, they have also done the similar kind of test, and they have found that in untreated glaucomatous patients you can find out if the peak which is found by water drinking test may match up the peak you are getting in your diurnal test. So this way you can use and find out whether the diurnals are affected and how much they are affected. So in summary, IOP is a dynamic factor, and circadian rhythm and spontaneous changes do affect it. It is known that IOP correlates well with progressive glaucoma damage, but the role of IOP fluctuation during the day and well as long-term fluctuation is not very clearly defined. Studies to date have some conflicting conclusions, but IOP fluctuations are worth considering as a risk factor for progression, especially in patients who carry a higher risk of visual field loss in the next 5 years. So coming to the treatment, although all the first-line topical agents have a considerable effect on the diurnal IOP lowering capacity, very few of them have the effect during the night, and therefore 24-hour diurnal curves are not the same for these drugs. Prostaglandin analogs are the only out of the whole group which are capable of achieving 24-hour control, but there is some variation in there also, whereas the carbonic anhydrase inhibitors, alpha agonists and beta blockers seem to have hardly any efficacy in the night time. So keeping these points in mind while we are treating patients would be a good point in our general picture. Thank you so much. Thank you very much.
Thank you, Dr. Manish. That was indeed a very informative talk. Thank you very much. We move on to Dr. Gauri. Yes, please.
Thank you, Dr. Chandrima. I wish you all a very happy Independence Day. I thank the Calcutta Ophthalmic Society and Dr. Chandrima for this invite. So my topic today is to discuss about the pitfalls of OCT in glaucoma. So we all know that OCT is a valuable tool that we all use in the detection of glaucoma. What does the OCT measure or look at? It either measures the retinal nerve fiber layer thickness by a measurement circle around the optic disc, and it also measures optic nerve head parameters. Or am I audible? Because I'm getting some echo.
Yes, Gauri, you're audible.
Yeah, thank you. So, or we also can look at the macular or ganglion cell thickness, because we know that the death of ganglion cells leads to macular thinning, and this fact can be used by looking at the macular ganglion cell thickness, and these are the ways in which we could detect glaucoma. So having said that, let's look at what are the artifacts. I mean, the way that we could detect artifacts in a OCT printout. The first factor that you will look at is the optic disc size. When you're looking at the optic nerve head analysis, optic disc size is very important. A large disc which is greater than 3 square millimeters has larger false negatives, and the small disc has false positives. So larger discs have lower sensitivity for early glaucoma, according to the paper published by Medeiros et al., because larger discs start with thicker RNFL measurements and they must suffer more damage before registering as abnormal on the OCT. Whereas a smaller disc is associated with the OCT RNFL being false positive. The next thing is the signal strength. So the scan quality, as we all know, affects the OCT performance even within the manufacturer recommended limits, and this effect is greater on the RNFL than on the ONH and the ganglion cell complex. So low signal strength causes artifactual thinning of the retinal nerve fiber layer, and cataract is the major culprit that can lead to a low signal strength. And we all should be aware of the minimal acceptable signal strength for the various machines that we use. And these are the things. So whichever machine you use, know which is the acceptable signal strength beyond which it is considered as a inadequate signal and the scan cannot be interpreted properly. So there are also certain operator related artifacts and from the scanning technique. So if the operator has not instructed the patient correctly about where he or she should see and about blink and eye movement during the scan, it produces lot of artifacts like you can see in this particular scan over here. These black areas are where you have no data or the patient has blinked, or you can see that these things are due to the inappropriate scan technique which has been used. And so this is also to be minimized with careful training of the operators. And the other thing that you also have to look at is truncation of the scan. So you get this cross section of the Tisnet, the circle, the RNFL circle, and if one portion is cut off like this, that means that you don't have enough data to interpret the particular OCT scan. So cutting off a portion of the scan due to misalignment is to be looked at. And this, as I mentioned earlier, is absent data due to blinking. So if you have blinking during acquisition of the scans, you have a dark black band which comes across the scan, and such scans cannot be interpreted. And micro eye movements, though there are tracking mechanisms in the OCT scan, you can see that this vessel here, there is a line where it cuts and then you have it disjointed over here. So these are due to small eye movements during scan acquisition, which results in an abrupt horizontal cutoff. So this is also not an appropriate one. And sometimes you have shadow images due to eye movement. So you can see that there are two veins here. The image is like there is a shadow of each image that you see. So here also the image analysis will be inaccurate and the scan should be discarded. And let's look at certain patient-specific artifacts. So in this patient, there is a PVD. And because of this PVD, the Weiss ring, it interferes with the imaging of the ONH, BMO and the minimum rim width. And so you can see that in this particular area, the imaging is not able to image the underlying structures. So this will be a poor quality image which cannot be interpreted. The optic nerve head analysis depends on the detection of the Brooks membrane opening. So earlier Heidelberg scans used to have us mark the edge of the optic nerve, but now it is automated where the machine detects the Brooks membrane opening. So you can see in this particular scan that the Brooks membrane opening has been imaged to be inside the optic nerve head. So like you can see here, it is inside the optic nerve head, and you have three sectors being marked as borderline. So this is due to inaccurate BMO detection, and there is an option for you to correct the Brooks membrane opening. You can verify and you can correct it. So once I have corrected the Brooks membrane opening, you can see that these sectors have turned out to be totally normal. So there is a display like this on the machine. This is the Heidelberg scan, and you can go and you can alter if the machine has wrongly detected the Brooks membrane opening. The other factor is centration. So here you can see that the circle is decentered over the disc, and therefore these sectors are determined as borderline. And if you see the fields of this patient, it is mild generalized depression, but otherwise totally normal, BFI of 100%. And so if you properly center the scan, that would turn out to be normal as well. Next, you have a small opacity over here, a vitreous opacity, which is causing shadowing. You can see that the details on the scan are not available. So you have this gap over here, and these sectors are marked in white. That is, the machine does not have any data, so no classification is possible. So if you have dense vitreous opacities, that can lead to shadowing and loss of image information. Also, sometimes blood vessels can give rise to an apparent increase in thickness and can cause a back shadow. So here you can see that there is a big blood vessel over here, and this causes, see this scan here, the green arrow, this is where the scan is taken. So you have this big vein over here which is imaged, and this vein causes shadowing over here. So there is a loss of data. And here the minimum rim width is wrongly marked because of this shadowing. And here you have a blood vessel which causes an apparent increase in thickness. This again is a blood vessel. This is the axis of the scan. This is the vessel which is imaged over here. And so this increase in the thickness is what leads to this scan going into the green area where it is all in the yellow area. So blood vessels can cause apparent increase in the thickness as well. And the other thing that we have to look out for is myelinated nerve fibers. So you can see these myelinated nerve fibers here, which is scanned over here. It causes back shadowing. So the structures behind are not imaged appropriately, and this can also cause certain artifacts from cropping up. So again, here you can see these myelinated nerve fibers here, and that causes, and here as well, and this causes an apparent increase in the RNFL thickness. So in the right eye, the circle is outside of this myelinated nerve fiber, so it has not affected it much. But in the left eye, you can see this circle is going through the area of myelination. So here, this increased thickness that you see is because of the myelinated nerve fiber. And as I mentioned earlier, vitreous opacities, here it is a little away from the disc. And this can cause a problem when you are looking at the imaging. You can see this particular graph which goes above the green zone is because of the opacity that you are seeing. Also, if you have epiretinal membranes, like there is an incomplete PVD over here, PVD is still occurring and there is traction in these areas. And so now here, the RNFL, which is thickness which is calculated, takes into account this traction as well, and this causes an apparent increase in the thickness of the RNFL. So you should be wary of this. And again here, the RNFL thickness here, that area of traction, it passes through this, the circle. And so here you can see that the thickness is calculated as way above normal, and so this graph goes much above the green zone, which is the normal zone. So this is erroneous, and you should look at this. You should look at the segmentation. See, this is the RNFL, and this is inaccurately taken as this layer to this layer. So it will be very thick. And in such cases, if you shift the circle to the larger circle, so this was the circle which was taking it earlier. So when we shift it to the larger RNFL calculation circle, this is a more accurate segmentation, and you can see that this RNFL thickness is more accurate and can be used in the follow-up when compared to the earlier scan. And this also correlates with the visual field of the patient, which is totally normal. So that brings us to the point is that we have to look at the segmentation of the scan. So in this, you have to go back to the machine and look at the scans. This may not be adequately displayed on your printouts. So this is the segmentation, the internal limiting membrane and the RNFL. So this is the layer which is taken up. So you have to go back to the scan and see if the segmentation has been done correctly or not. So let's look at examples of inaccurate segmentation. An example of inaccurate anterior segmentation. So you can see here, this segmentation has passed through the RNFL. So the RNFL is thicker than the segmentation. So this can cause the tissue graft to dip. So you go back in the scan and look for it, and you can see that in this particular patient, though the RNFL was detected to be borderline, the GCIPL or the ganglion cell layer thickness at the macula is totally normal. So that's another tip. Always correlate the RNFL scan with the macular thickness map that you will find in the OCT. So let's look at an example of incorrect posterior segmentation. Here the anterior segmentation is normal, but the posterior segmentation, this blue line, you can see is going up here where it should have been at this point. So here inaccurately the RNFL is being displayed as less thick than it actually is. So unless you go back to the scan and look at it, you won't know. And again here you can see that the macular thickness, this donut here, the macular thickness is quite normal. So that gives you a clue that this is not due to a problem but due to an artifact. In this case it is the inaccurate segmentation. So again, you have a segmentation artifact here, the posterior segmentation, the blue line. You can see that it goes up here, almost at the red line. So it is saying inaccurately that the RNFL layer is not there at all in this portion. So that's why you have this tissue graft dip over here and this nasal sector being shown as in the red. But it is not actually the case. This is because of a segmentation artifact. Again, eyes with PPA. So this is a high myope with peripapillary atrophy, and here segmentation will be erroneous. The machine will be very confused as to where the RNFL starts and ends, and you can definitely not interpret such scans. So you have a tilted disc with a peripapillary atrophy, and this peripapillary atrophy is here. This looks quite good, but then you have to make sure that the circle is outside of the peripapillary atrophy in order to interpret these scans. Here the fields of the patient is totally normal, and here the scan is showing some changes, maybe because of the disc being tilted. So you would go by the fields and not just rely on the OCT in this patient. So let us look at peripapillary atrophy and RNFL in detail. So in this scan, there is a large area of peripapillary atrophy and the circle passes through it. And so you have inaccurate segmentation and inaccurate tissue graft. So when you increase the circle diameter, you can see that the graph is better and the segmentation is slightly better, but even now it is inaccurate. And if you go to the more larger circle, then you have a slightly more accurate scan over here. But even here, the segmentation, as you can see, is far from satisfactory. So these are ways in which you can overcome the PPA, but the scan quality may not be very good in such eyes. So again, you have a unilateral pathological myopia with tilted disc, and you can see that there's a lot of abnormality in the retina over here, and segmentation artifacts are very, very significant. So such scans cannot be taken at all. So let's come to something known as a green disease. In OCT, green signifies normal. So if we see everything green, like you can see in this sectors here, you think that the eye is normal. But then there can be some defects which are missed here. So here you can see this is the red-free image, and very clearly there is an RNFL defect over here marked by the black arrows. But then because this is a very focal defect, when you look at the RNFL thickness, though the graph dips here towards the yellow zone, when it is averaged, the thickness is normal. So in the quadrant and sector analysis of the RNFL thickness, this will be shown as normal or green. but look at the ganglion cell thickness, the macular map. So here you can see that this is deficient. So this is the RNFL defect which is causing this decreased thickness in the macular ganglion cell layer. So one should always correlate this, and small localized defects can be picked up better on the macular thickness map than on the RNFL analysis. Another example of the green disease, here the RNFL defects are not very clear when you look at it, but there is one here and one more here. But the RNFL thickness is being shown as completely green, and macular thickness is also showing not very significant defects. But look at the red free image, you can see that this is a very clear wedge-shaped RNFL defect, and here and here. So if you go by the green here and this one, you will miss this glaucoma. So always correlate clinically. Okay, and then here, if you make the circle a little, the middle circle, then this is the area of the RNFL defect, and you can see that the graph is actually dipping. So you have to go back to the Tisnit graph and look at what is happening over here in the area of the RNFL defect. So the OCT is picking up, but it is being averaged out because of the thicker adjacent layers. So one needs to have a reliability checklist, look at the signal strength adequacy, cataracts, PCO, dry eye can cause errors. Is there a traction or a torsion error? Is there correct segmentation of layer boundaries? Is there presence of additional retinal or vitreous pathology? Very importantly, look whether the RNFL loss matches up with the macular or the GCIPL loss. Is the macular thickness loss in an arcuate problem? Another important thing is inflammation. In a patient with uveitis and glaucoma, because of subclinical retinal edema, the RNFL may be showing as wrongly normal, and once the uveitis comes under control, the RNFL thickness decreases and you can see the defect. So this is something that you need to bear in mind when you're looking at secondary glaucomas due to uveitis. Look at coexisting retinal diseases. So in summary, look for presence of tilted discs and peripapillary atrophy. Most importantly, correlate with the clinical examination of the disc and retina and visual fields. And in conclusion, the important thing is that the machine doesn't have a brain. You should use yours, and management decisions should not be based on the input of the imaging device, at least. I mean, only. You should place less weight on a test if there are any concern about the device's performance in a particular patient. Reject images taken at extremes of refractive error. So more than -12 and +8, the images are not having any normative database. So reject such images and images of poor quality. And this is what I will conclude with. Thank you very much.
Thank you, Dr. Gauri. As usual, that was a great presentation. We move on to Dr. Shanta.
I have to stop sharing just a second.
Yeah.
Yeah, thank you.
Dr. Shanta, are you here?
Yeah, I'm just beginning the share. Thanks for the invitation. It has been wonderful so far, and really lovely presentations. I've been really fortunate to have been invited. This system is taking a little time. Please bear with me. I'm sorry, my connection is a little slow.
Okay. So, could we?
Yeah, no, it is coming through. The connection is a little unstable. It will come through. Just give me a second.
That's fine. Can we just take one question in the meantime? Then there are lots of questions. Oh, there you are. Okay, yeah.
So my topic is role of imaging in the management of childhood glaucoma. This role of imaging can be threefold: diagnostic, therapeutic, and for research purposes as well. The types of imaging can be anterior segment OCT and swept source OCT as well as UBM. AS-OCT, we have already been told, uses low coherence infrared light. Now we use longer wavelengths of 1310 nanometers, so this allows penetration through the sclera and the limbus. However, you are not able to see structures in the posterior chamber and details of the ciliary body are not visible. It is a non-contact technique and therefore more acceptable to children. So this was imaging of the anterior segment using handheld OCT in congenital glaucoma. It was reported by Pilot et al. And you can see that the temporal and nasal angle has been visualized here. The structures are clearly seen: the scleral spur, the Schlemm's canal, the iris vessels, the trabecular meshwork, and the Strawberry's line. So a lot of detail is available. This was in this study, they also looked at the corneal changes and contrasted it with the normal eyes. You can see here the increased corneal edema and thickening, and you can see abnormalities of the posterior layer of the cornea caused by the HAP striae, thickening of the posterior corneal layer wherever HAP striae is present. You get iris changes as well. When you compare with the normal eye, you can see that there is flattening of the iris collarette. The crypts are also absent and thinning of the stroma is present compared to normal eyes. Now we have used the handheld OCT in the management of a patient who was diagnosed to have primary congenital glaucoma, underwent combined external trabeculotomy and trabeculectomy. The cornea cleared up significantly on the first postoperative day, but the parents brought the child 3 days later with history of sudden whitening of the cornea, as you can see here. So with the handheld OCT, we were able to visualize a Descemet's tear in the infotemporal quadrant at the paracentesis site, and this had led to gross corneal edema as is visualized here. So using the handheld OCT, we were able to image the extent of this edema and find a location through which pneumatic descemetopexy could be done using a 27 gauge needle mounted on a 2 ml syringe filled with sterile air. And this is the postoperative result. You can see that the cornea has cleared up considerably and the layers of the cornea are now much more clearly visualized. This is a paper on AS-OCT in aniridia, and we have all assumed that angle closure is the most common pathogenesis of glaucoma in aniridia. Surprisingly, in this paper with AS-OCT, they found that in 50 of 54 eyes with glaucoma, it was open angles compared to only 7% with angle closure, and this has been our experience as well. Peters anomaly is a rare condition which gives rise to glaucoma. You can see the thickening of the cornea here, and in some areas, a deficiency of the cornea is present as well. Neovascular glaucoma is uncommon in children but does cause extensive synechial closure, and you can contrast this with primary congenital glaucoma where you have a normal anterior chamber depth, sometimes even a deep anterior chamber with a wide open angle and a flat contour of the iris. What about the role in research? This was an interesting paper where they looked at the effect on the angle in eyes which have undergone lensectomy in childhood, and you know that a large number of them, especially aphakic eyes, develop glaucoma over a period of time. And these were the measurements that they took of Schlemm's canal, which was imaged very nicely. They took the images in normal eyes, in post-lensectomy eyes, and in post-lensectomy glaucomatous eyes. And they looked at the effect of accommodation and without accommodation also. And what was interesting is that they found that the dimensions of the Schlemm's canal and the cross-sectional area were smaller in eyes which had undergone lensectomy, especially in the glaucomatous eyes. An accommodative effort increased the Schlemm's canal size in healthy eyes, but not in eyes which had undergone lensectomy. So this was a cross-sectional study which showed that a reduction in Schlemm's canal did occur in eyes which had undergone lensectomy and may result in a reduction in the outflow facility. But you need a longitudinal cohort study to see whether there is a cause and effect relationship. We also know that anterior iris insertion is a pathogenetic factor in eyes with primary congenital glaucoma. This is the normal portion of the same eye where you can see the trabecular meshwork clearly, but you can see anterior iris insertion in another part of the nasal angle of the same eye, which is responsible for the pathogenesis. Anterior iris insertion is common in post-lensectomy eyes also, and we found that this was much more frequent in eyes which had been operated at a very young age. and young age was found to be a predictive risk factor for the development of glaucoma in post-lensectomy eyes. What about UBM? You can perform it in the supine position, but you need examination under anesthesia in very young infants and children. The posterior chamber can be imaged, and you can see the ciliary body and the extent of damage in the posterior chamber. 80 megahertz probes can be used to image the Schlemm's canal. And this was a paper which looked at the anterior chamber angle structures in patients with primary congenital glaucoma. And although this patient has a wide open angle, you can see that there is a membrane obstructing the angle structures and there's absence of Schlemm's canal. Quantitative analysis is possible. This is the Schlemm's canal which was visualized and measured in this particular paper. What about UBM in patients with rare diseases of the anterior segment? You can see this is Axenfeld-Rieger syndrome with adhesions of the iris to the peripheral cornea. And this is a UBM done in a child with aniridia with open angle in one side and synovial angle closure in another part of the same eye. It's important in decision making. This was a 2-month-old child who presented to us with infantile diabetes mellitus and extremely large corneas, about 18 millimeters in diameter. We could not make out any anterior segment details, but suspected that there must be some type of pupillary block. And you can see that with the UBM, the iris is plastered to the posterior surface of the cornea, the secondary angle closure, and the lens was not visualized. So this was a congenital aphakia with secondary angle closure. It helped us with decision making. External trabeculotomy with ectomy was not possible, so we did a trabeclectomy with mitomycin alone. This was done in both eyes, but the short-term results were good, but long-term results were poor, and the child needed multiple episodes of diode cyclophotocoagulation. Very often tube implants are used to control glaucoma in infants, and one of the problems is a tube corneal touch. So in this patient, you can see that there's sufficient space between the posterior surface of the cornea and the implant. This was another post-PK secondary angle closure glaucoma in which AGV implant had been introduced, but within 6 months we couldn't visualize the tube position anymore. But with the UBM, we were able to visualize that it was in the anterior chamber and still functioning. So in conclusion, imaging is a useful tool to assess the pathogenesis of congenital glaucoma and abnormal anterior segmental stenosis. Planning of surgery is facilitated and intraoperative assessment is possible in selected cases. Thank you.
Thank you, Dr. Shanta. That was indeed a brilliant presentation. Wonderful. I looked at the pictures with awe and they were so well interpreted by you. Thank you very much. Wonderful.
Thank you so much.
So we move on to Dr. Shushma for the next presentation.
And thanks so much, Dr. Chandrima, for having me here. It's a privilege being part of Kolkata Academic annual meeting. And for me, it has been more of a learning. Wonderful talks by Dr. Gauri, Dr. Shanta, and Dr. Manish. I've been enjoying that. I'll start with how UBM has changed our practice. Is my screen visible?
Yes, yes.
So, right. Well, Dr. Shanta has already helped me with starting with UBM's role in pediatric glaucoma, and of course, it is indeed a very useful tool in certain situations for that matter. Well, this is a high frequency ultrasound device, and the best part of UBM is that its ability to visualize the ciliary body and lens behind the iris, which is not possible to look at with other instruments like ASOCT. The disadvantage being is heavily operator dependent, so we need a skillful technician, or we have to do it ourselves, and we need to understand how to do it. It does have a little longer image acquisition time, and we need to realize that it images only one cross section at each time point, so we need to keep in mind. It is often compared with the ASOCT, but if you look at UBM is more of a contact method, although with newer devices we do have we do have contact methods, but it can also be done in sitting position, possible to do in children and sick patients also. We can visualize the posterior part or the iris, the part behind the iris, so that it has its advantage over ASOCT for that. You can even look at the anterior vitreous space, pars plana, and lens. And through opaque cornea and sclera also we can have the understanding of the anterior segment so that we can take important decisions for treatment of such situations. So there is a possibility to look at the qualitative anterior chamber angle analysis. You can even look at, like in this, you can see the image in the same patient in the dark and the light, how the angle opens up. And this particular thing can be used also for looking at how the angle opens up after the laser PI, like in this situation. So the qualitative assessment is definitely there, and as mentioned by Dr. Shanta, the quantitative assessment is also possible with UBM. So you can look at the angle opening distance or the trabecular iris space area so as to understand that how much is the angle open for various situations, whether it is an angle closure or you're planning an ICL and things like that. So another important situation where UBM can be useful is plateau iris. You can detect plateau iris by gonioscopy and confirm it by using UBM, and it can clearly show you that how there is absence of ciliary sulcus, and you can see ciliary body rotation, iris angulation, which can confirm the diagnosis of plateau iris and help us plan the management. There are a few examples that I would show you of different situations where UBM can be useful. This is a 23-year-old female who came to us with decreased vision since last 1 week after the treatment of migraine. So visual acuity had decreased and pressure had increased. So classical, choroid effusion or secondary angle closure due to topiramate is something that can be picked up on UBM. Earlier situation than that was something that we saw in a patient who came with dengue fever, and 30-year-old came with a sudden drop in vision since 2 days. So visual acuity had dropped to 618 and suddenly he had developed myopia, although the pressures and all were normal. So when we did the UBM, the same thing, there was a ciliocoroidal effusion that was cropping up. So when we looked at the list of medication he was on, we stopped Emisset and started topical steroids, and within a week it could resolve, and visual acuity was back to 6s unaided. So those are certain things that where UBM has an important role. Well, also in trabeculectomy bleb evaluation, when we have to look at whether the functionality of the bleb, so you can actually see whether the internal ostium is open, whether there are cystic changes, or the bleb is flat or overfiltering, or there are enough cysts to understand whether it is functional, is something that is possible by UBM. This is a child who presented to us with buphthalmos, both eyes, 3-month-old, and there was opaque cornea in the left eye, and UBM can very well show us that there was a DM split and hydrops due to that, and so we could treat accordingly. This is another child who was 20 days old and presented with unilateral buphthalmos. As you can see, this eye is bigger, and the pressure in the left eye was as high as 46, and there was a shallow anterior chamber. When we did a B scan, there was no mass or bleed because it looked like a secondary angle closure. So we were looking at the posterior segment pathology. So if you look at the slit lamp image here, this is taken with a handheld slit lamp. This was, the right eye had a formed AC, but left eye was almost flat anterior chamber. So when he did the ultrasound, as I said, it was normal, and the axial length was quite different. It was 22, and interestingly, the AC depth shown by the A scan was 3.25. So which was larger than the right eye as well, whereas clinically we were seeing the flat anterior chamber. So B scan came to rescue. So if you look at, this is the cornea and this is the iris or a hyperreflective membrane here, and this was the lens behind. So this is what we were seeing clinically as anterior chamber depth, and this was the actual anterior chamber depth which was picked up by the A scan. So diagnosis became easy. This was a pupillary block due to inflammatory membrane, and we could do membranectomy with the simple surgical PI, which could help us resolve this situation. Another patient with a unilateral glaucoma with corneal haze and scarring, and you can see there were pedicle anterior synechiae. So we know that how to go ahead further. It will not be only taken care by a trab alone. So such situations UBM does come handy. Another interesting situation where we could assess the bleb well with the UBM was a child with Ahmed valve that was done almost say 6 to 8 months back, and now the pressure had started increasing. There was a minimal corneal haze on the side, and there was a large diffuse bleb surrounding the body of the valve, but the pressure had started increasing. So when we did the UBM over this bleb, by keeping the cup on this bleb, we could see there was a very thick fibrotic capsule around the shunt. This was the shunt body, and you can see the fluid there and the thick fibrous wall around. So this is what had to be done. This fibrotic capsule had to be excised for the valve to function back. Another situation where we put the tube in the sulcus and sometimes it is behind the iris. You cannot figure out why it is not working. UBM comes handy, and here you can see the tube in the sulcus which is blocked by the iris. Well, a very important use also of UBM is to do the ICL sizing that it is used for. However, in terms of, it's not only for measurement, but you can look at many situations where you may not like to put an ICL. So in addition to the sizing, you can also look at the iris configuration or the lens vault, which can, so that you can rule out conditions where you should not be advising an ICL. And small subtle things like such kind of a cyst in the iris may misalign the ICL, and those are the things that can be picked up easily by UBM. Another interesting situation where post ICL the patient had high pressures, and the PI, although the PI was patent, as you can look at. So this is a high vault, and you can, with UBM you can even quantify the amount of vault that you have, and we know that with the more than 1000 micron high vaults can cause endothelial damage, pigment dispersion, and angle closure glaucoma. So you have to be treating them accordingly. Another, and this is the most important use of UBM that we use in patients with opaque cornea. So when you have to manage opaque cornea and need to understand whether what you should be doing for glaucoma, whether it has a potential of vision or no, and those things where we can easily understand whether it is a disorganized anterior segment or there is a well placed iris and pupil and lens, so that accordingly you can plan your management. Another condition, this is the last one I think, that is malignant glaucoma, where you expect a pressure to be high and shallow anterior chamber, patent PI. In certain situations these diagnoses can be confused with other things. So in UBM you can very clearly see the anterior rotation of the ciliary body and can diagnose aqueous misdirection and treat the patient accordingly. So basically it's a very robust tool for glaucoma to identify pathology in anterior chamber angle, anterior segment, sclera, ciliary body, lens and choroid, and also useful for assessing the bleb. It is the only simple tool to assess the anterior segment structures in opaque media, and that is why it is important for planning management of complex situation. Even for anterior and angle closure glaucoma, UBM has a clear advantage in visualizing the structures behind the iris, which is important for ruling out plateau iris or the small iridociliary cysts like that. Well, thank you for your kind attention.
Thank you, Sushma, for your wonderful presentation and very superb pictures you have given for the UBM. Thank you very much. Just because of shortage of time, we are going for 2 questions. I'm audible, I hope?
Yes.
Yeah. This is for Dr. Krishna Das. Are you there? Krishna? Dr. Krishna Das?
It's probably not there.
Okay. Just for the groups of doctors who are there, one question has come: at what IOP, intraocular pressure, should the treatment be started in ocular hypertension? Vinay, I want to ask. At what intraocular pressure should treatment be started in case of OAC, ocular hypertension?
I don't think that you can set a pressure like that. Actually, I think it depends on various parameters. For example, the appearance of the optic disc, and at the time that these indications for starting treatment came out, we had in the first study not taken into consideration the central corneal thickness, and also that we didn't have any retinal nerve fiber layer and ganglion cell layer assessments at that point actually. So also the other parameters are that whether there's a family history and what's happening to the other eye and other risk factors. So I think you have to take everything into account before you end up starting someone on treatment actually, which what I'm trying to say is that you can have someone at 21 or 22 millimeters of mercury. You might classify that person as an ocular hypertensive, and you may have sufficient reason to start him on treatment, whereas you may have someone at 25 millimeters of mercury, but you may not have enough justification to start this patient on treatment actually.
Anyone want to say anything about that? Any comment from any others? Okay.
Just to add,
Just one question. Yeah. Yes, Shobik?
I think what Dr. Mangia sir has told, this is just in continuation with Dr. Krishnaraja sir, only to state that whether you should treat all with a defined intraocular pressure, it has been taken by OATS 3 trial. OATS 3 is already underway, but they are advising almost all to treat. Number one point. Number 2 point is that very beautifully Dr. Krishnas has pointed out the various, particularly angle parameters. Angle parameters are not in the OATS 1 or 2D study, and in Indian context, those are very important. And I had actually question, I have a question for sir, that the prediction model, either by the continuous method or the point system, we all know there is a predictable tool for who are likely to get glaucoma in these groups, including age, vertical curvature ratio, at least 3 measurement of IOP, CCT, and PSD deviation. Angle was not included. So, in Indian context, whether the gonioscopy feature should be incorporated there or not.
Okay, the question is still there. I'm shifting to the next question because shortage of time. This is a Meenakshi. Meenakshi, are you there?
Yes, yes, sir.
Yeah. In case of supposedly apposition closure of angles with mature cataract, how to go ahead? Should YAG-P be done before, then dilated fundus examination, or the other examination for the anterior segment for fear of acute attack? Should we go for the PI in case of apposition closure of angles with mature cataract early or on the same sitting? Others.
If there is we are talking of mature cataract and an appositional closure.
That's right.
Yeah, and so if we are able to do a PI, I would say it would. I would prefer to do a PI if it is possible, and then go ahead with the cataract surgery. Either way, there is no possibility of looking at the fundus and evaluating other things because no view of the fundus. Doing the PI would prevent the patient from going into an inadvertent high IOP either on the table when we are planning to do the surgery. A mature cataract, either way, we would not be dilating for any other reason except to do the surgery. So if we have done the PI, I think it will give us a room for safety, and we can also, such patients should be given a mannitol on the table preferably so as to decrease the vitreous pressure and do a very careful surgery. And most patients who have this patient may be either way prone to an angle closure, and so if we, by seeing the IOL power, we can realize whether it's a small eye, and also by doing a specular, which very often these patients may have a low cell count. So these things can be kept in mind, and one can go for a very guarded and careful surgery and remove the lens. Also,
okay, you can say, please.
Also, some people feel that, in this case, it is an appositional closure. So this will be the choice. But if it had been actually a phacomorphic and it had there was a history of more than 7 days and we could actually get cynical closure, we may think of doing a combined surgery. What are the other views? It will be interesting to hear.
But you have to look for the other eye also to access the condition.
Yes.
Okay, thank you. Now we're shifting to the next one. Shurajit, I'll go to the case presentation.
So with the one question for Dr.
But shortage of time.
We'll come to it later.
Later.
Yeah.
Too shortage of time. Shurajit,
Presentations are waiting. Yeah.
the case presenters.
Dr. Devang Angmo. Dr. Devang, can you share your screen? Are you there?
Yes, ma'am. Yes, ma'am. I have shared my screen. Is my screen visible?
Yes. Perfect. Yeah.
Until there.
Good evening, everyone. At the outset, I would like to thank Dr. Chandrama and the Kolkata Academy of Ophthalmology for the invite. I would be presenting a case of neovascular glaucoma, a Pandora's box. So this was a 52-year-old female resident of Bihar and a teacher by occupation who had presented with a gradually progressive painless diminution of vision in the right eye since 1 year to us. So if you look at her past illness, she had shown in a private hospital at Patna where she was diagnosed as a case of primary angle closure glaucoma with a right eye proliferative diabetic retinopathy. She was started on timolol drops and she was also given some injections for which there were no records, but the patient had a wrapper of Tenocort when she had come to us, and she also told us that she had a laser PI done, laser was done, and so in the right eye there was some injection given which was a bit expensive, but again there were no records, and she was advised surgery in the right eye. So she further came to us for a second opinion. So if you look at the past history, she was a known case of diabetes since 10 years, and she was on oral hypoglycemics and she was controlled. She also had a history of pulmonary TB for which she had taken full treatment and she was declared cured. Her family history was insignificant and there was no history of any drug allergy. On doing a systemic evaluation, it looked within normal range. However, the carotid pulse on the right side showed a significant bounding. So if you look at the ocular examination, the visual acuity in the right eye was 2/60, which didn't improve further, whereas in the left eye it was 6/80, improving to 6/12. If you look on the presentation, she had a corneal edema, and on doing a gonioscopy, there was a neovascularization of the angle and broad-based peripheral anterior synechiae in the right eye. Whereas in the left eye, we could see few goniosynechiae with fine PAF also. However, we could not see any NVI in either of the eye, and the PI were patent in both the eyes. In the right eye, we noted a RAPD, and the IOP on presentation was 30 millimeters of mercury in the right eye and 20 in the left eye on tablet Diamox and eye drop iotin brimonidine combination, which the patient was putting in both the eyes at presentation. So when we look at the fundus examination, so if we look at the disc, we can characteristically see that there are neovascularization of the disc along with a significant arteriolar attenuation, which is characteristically seen, and we could see dot hemorrhages, especially in the mid-peripheral area and that too in the nasal areas. And when we did a fluorescein fundus angiography, there were supratemporal microaneurysms. The cupping, as you can see, is around 0.8:1. If you come into the left eye, we see that the cupping is around 0.7 to 0.8, and there is a mild arteriolar attenuation, and very fine dot hemorrhages can be seen at the posterior pole. So we then investigated the patient. Her hemogram, it seemed to be within normal limits. Her blood sugars also were within the normal range. However, the HbA1c was around 7.1. Her liver function and kidney function tests were also within normal limits. Her lipid profile was borderline, and the serum homocysteine levels were also within normal limits. We did a field in the right eye. She had a very constricted and a limited field. In the left eye, because it was a first field, there was a severely depressed fields. So we probably would subsequently do wait for the subsequent fields. We went ahead and did a FFA. On the fluorescein angiography, we could see that there was a prolonged retinal arteriovenous time, prolonged choroidal filling time, and we could see a mild peripheral capillary non-proficient areas along with microaneurysms in the right eye. In the left eye, we could only see few microaneurysms, and we could not see any NVE at either of the eyes. So then, after discussing with our retina colleagues, we went ahead and did a carotid Doppler just to see that there was an eccentric plaque in the right carotid bulb extending into the right internal carotid artery, which is causing over 90% of the stenosis. And then after discussing with the medicine guys, they had suggested for a 2D echo, in which we had noted a grade 1 left ventricular diastolic dysfunction along with a concentric left ventricular hypertrophy. So these are our differential diagnosis, whether is it a case of vascular occlusion, or is it a case of PDR, or is it a case of hyperviscosity syndrome. So these are the points to ponder. What, according to the differential diagnosis, what will be the final diagnosis, and why are we discussing this case? And this would be subsequently discussed by my discussant, Dr. Vinita. I would like to thank for the kind attention.
Dr. Vinita, would you come on with the discussion, please? Dr. Vinita, are you there? Are you there, Dr. Vinita?
Yeah. Hello. Thank you, Dr. Chandrima. Nice case, Dr. Devang. It's a rare case because ocular ischemic syndrome per se is uncommon. We can think of a common entity like CRVO or diabetic retinopathy in this case. Though it is partially treated case and it's a very long history of 1 year, so there could be some changes which are being altered because of the previous treatment and previous injections. But definitely it looks like an ocular ischemic syndrome because there is a carotid artery blockage. Usually this occurs after the age of 50 years, though there is a male preponderance, but it can occur with a percentage of say about 90% or more block. So as I discussed with Dr. Devang, there is a 90% block in the right eye, so which goes in a favor of ocular ischemic syndrome. Though we have to look into the left eye carotid artery also, because in 20% of the patients there could be a bilateral involvement. Besides right eye, the left eye also shows a very advanced glaucomatous changes in the form of a fields. So it is better to take RFNL thickness on OCT and see for the macular OCT of both the eyes. The internist will help a lot in this case because carotid, beside carotid, the coronary artery involvement and the incidence of the stroke will be higher. And even the mortality in such case is more. So there is a 40% risk of death in 5 years. So we have to take into consideration the treatment not only from the eye point of view, but also from the systemic point of the view. We can go for further studies, maybe an ocular perfusion study, maybe we can go for an ICG to know the choroidal circulation, but they are all of a ERG also to know the A and B wave status. Definitely we have to protect the left eye because left eye is also quite an advanced glaucoma, and with the Diamox the pressure is very high. So we have to treat both eyes glaucoma. Mostly it looks like a primary angle closure glaucoma. On top of it, the ischemia in the right eye. And probably we have to treat left eye medically and right eye maybe trabeculectomy or shunts after doing a PRP. So this is my take home. Thank you so much.
Thank you. Could we have the panelists with the take home message, please? Dr. Aparna and Dr. Bhaskar. Are you there?
Yeah. The thing is that what Dr. Vinita said, the mortality rate is very high in this type of patients because in 5 years' time, 80% patients die, and in 1 year time, one-sided eye vision gets lost. And apart from doing a lipid profile, which is a borderline, you have to also see the apoprotein, lipoprotein, and the fibrinogen, LPA level. These are also are significant in case of this type of coronary arterial diseases. And the most interesting point is that if it is a ocular ischemic syndrome, in 90% cases we develop MVG, but in that case the IOP is low. But here the IOP is high; it is about 30, as mentioned by the case presenter. So it is probably ocular ischemic syndrome has to be ruled out. Other things also. That's my take-home message.
Thank you. Dr. Aparna, are you here? I don't think so because her net connection is very poor. So we move on to the next case. Dr. Purvi, could you please share your screen?
Thank you, Dr. Chandrima and the KAO team for inviting me for this session. And I don't mind skipping my dinner today because it's been an absolute feast listening to all the presentations and seeing through all those images. So My case is actually very simple, but it's basically to emphasize how sometimes missing on the simple things, we make the things very complicated. So I hope the screen is visible.
Yes, very clear.
So the patient I'm talking about, basically she is a female, 45 years and residing locally. And she came to us with the complaint of pain in both the eyes off and on, aggravated since 3 months, but this was her originally initial complaint since 2 years, because of which she had earlier consulted another ophthalmologist. And the pain was associated with headache, which was diffuse and also off and on. And she has a history of using glasses since 9 years. When she came to us, the treatment she was using is both histimolol and latanoprost, along with that left eye brimonidine and dorzolamide, and along with all these topical drugs, she was on liquid glycerol 3 times a day. And this was her correction. I put the actual snapshots from the case to get the realistic view. So this is her correction, nothing very significant. When we examined her, the significant things which we found were the right eye was having a single but patent PI, and the left eye had 2 patent PI. The Goldman applanation tonometry was both eye 17, and it was a normal pachymetry. And in the gonioscopy, the scleral spur was visible only in parts. The angles were over 2 to 3, and the iris also had a variable configuration varying from flat to convex. And the central fundus showed a normal healthy disc. This image is slightly overexposed, but both the discs were absolutely normal, healthy NRRs and absolutely normal fundi. And we have an octopus at play, so these are the octopus printouts, and you can see absolutely normal fields in both the eyes. And this was the OCT. Again, you can see absolutely in the green zones and nothing suspicious about the OCT as well. And so we still had to find out the cause of pain and headache in this female in spite of that medical treatment that was on. So we ruled out all the other causes of headache by occupation. She had a non-stressful job. She was a well life, no issues and no problems at home. Her orthoptics, all convergence, accommodation, everything normal. The compliance also, she was very compliant, so there was no reason to assume that the IOPs might be fluctuating in between, and there was no progression, as we could see from the last day scan field findings. So we thought that are we still missing out something, and what is the cause of pain and headache in this lady? And so we asked her to bring all the records which she had of the previous 2 years. And to our surprise, we found that all her sheets we saw that she had her IOPs measured in the NCT. You can see all the follow-ups they were done at the previous ophthalmologist, they were done on an NCT. And not only that, in an attempt to find the cause of pain and headache, the previous ophthalmologist has done multiple diurnal variations. You can see 8 a.m. to 8 p.m., 1, 2, and 3. And not only this, 4, 5, and 6. 6 diurnal variations have been done, and out of that only the 5th one was done with an applanation tonometer. The rest all were done on NCT. And again, surprisingly enough, even after the 8 a.m. recording and one of the DVTs were 54 and 52, the entire DVT was continued. And so this was of course a big hitch in the entire management, but what we proceeded to do was we did a UBM. And as Dr. Sushma just mentioned, UBM is a very useful tool to point out to certain missing findings. And what we could see here is the anteriorly rotated ciliary body, which is pushing the iris anteriorly. You can see the patent PI here, and you can see the anteriorly rotated ciliary body, which classically indicates a plateau iris. In the left eye also, you can see this anteriorly rotated ciliary body is there, and this peripheral hump, which could be seen in lots of the quadrants. So this was a classical case of both eyes plateau iris. We do not have the iridoplastic facility at our place, so what we did was we just added pilocarpine eye drops, and within a span of 10 days, you can see this was the UPM that was performed, and you can see the ciliary sulcus has started forming and the ciliary body has come down into its normal position. This is the right eye and this is the left eye. The ciliary body has fallen back, and you can see the iris contour has also become normal, and the patent PI, you can see it's still visible. So what we then did was we just continued pilocarpine eye drops, and to the entire medical treatment that was on, we went on a step down therapy, so first omitting the liquid glycerol and then gradually omitting all the drops one by one. And currently, at the end of about 6 months of follow-up, the patient is relieved of the pain and headache. The Goldman applanation tonometer varies between 12 to 14 millimeters. After the 6 diurnal variations, we do not, dare to call her for another DVT. We just call her at different times of the day, and it varies between this. The gonioscopy, the sclerospur is now well visible in all the angles, and the iris has assumed a flat configuration, and the patient is very well maintained on timolol and pilocarpine. She just preferred to use it BD now instead of a QDS dose because of the visual complaints that are associated with the drug. So my take-home message through this case would be, it is very important to diagnose correctly to treat the condition correctly. We need to remember that Goldman applanation tonometer is the gold standard for glaucoma. No NCT please for management of glaucoma patients. Always do a complete and accurate evaluation of your patients. All glaucomas are not simple primary open angle glaucomas or primary angle closure disease. We need to keep in mind the other variants that may exist. Whenever you do any other additional tests like the OCT we have seen the UPM and other imaging techniques, and even the DVT, the 24-hour IOP, IOP monitoring we understood. So we need to realize the actual methodology to do the test, what is its relevance and what is the inference of that test. We should not just do it for the sake of doing a test. And UPM, as already mentioned previously, is a very, very useful tool in the glaucoma diagnostics. And do reconsider your diagnosis whenever your routine treatment or your routine diagnostic protocol fails. Thank you so much.
Thank you, Dr. Purvi. That was a very interesting case. I'd like to ask Dr. Sanjay to complete the discussion, please. Dr. Sanjay? Yeah, discussion.
Hear me? Hello?
Yeah, we can hear you, but not clear.
Is it better?
Yes, yes, yes.
And team Kolkata Academy for inviting me. It was a very interesting case, nicely diagnosed and documented by Dr. Purvi Bhagat. And I would like to highlight certain points of this case. Is my slide visible?
Yes, yes, it's visible.
Plateau iris configuration is a preoperative condition which is diagnosed on indentation gonioscopy, and we classically see the double hump sign. And Plateau iris syndrome, on the other hand, is a postoperative condition which has a patent PI. So this is the basic difference between the two. And Plateau iris syndrome may be triggered spontaneously in darkness due to pupillary dilatation. And it is basically, as she said, that it is due to abnormal anterior position of the ciliary body. It is usually seen in young hyperopic females, and the mean age of diagnosis is around 35 years. The prevalence of Plateau iris syndrome by UBM in eyes at risk for primary angle closure varies from 32% to 54% in different studies. So it is quite common in patients who are at risk for angle closure. If we do UPM, maybe we find many more patients with Plateau iris configuration. And it is inherited as autosomal dominant pattern with incomplete penetrance. It can be classified into complete and incomplete varieties depending upon the level of trabecular meshwork, which is obliterated by the height of the Plateau iris. And as highlighted by Dr. Purvi Bhagat and Dr. Tejwani, UPM plays a very important role in this condition because it clearly demarcates the anatomy of the ciliary body, unlike anterior segment OCT. The treatment can be done medically by pilocarpine eye drops, but RM laser peripheral iridoplasty is the treatment of choice. And if everything fails, then we can go in for trabeculectomy or drainage valves. Another important thing to remember is that we should do regular follow-up with serial gonioscopy because angle closure may develop years after successful iridotomy or iridoplasty. And another important point is that since it has a hereditary component, all first-degree family relatives should be screened. Thank you.
Thank you very much. So the take-home message from the panelists, please.
Hello. Am I audible?
Yes, yes, you're audible, please.
Okay. So
Shobik, yes.
it was a really nice presentation from Dr. Bhagat. So if this is a very routine case, say 45 years old female came to us regularly, significant hypermetropic error is there. This normally we are tempted to do a laser PI at the first sitting without doing gonioscopy. This is the normal current trend everywhere. Particularly it is seen by general ophthalmologists who also practice glaucoma. Now my question to Dr. Purvi is that suppose you don't have UDM, you don't have any access to UDM, and the patient comes to you in the first time, then how you are going to manage her clinically? Because at least in in this part of the country also we are seeing this type of routine cases every day, and this type of headache, they are usually the initial roots are entirely different. Either it is migraine cluster headache or like this groups on the one side, or something happening at the angle on the other side. So suppose we don't have any access to UBM, then how clinically you are going to deal with this patient?
Yeah, if in case the UBM is not available, even if you do a good gonioscopy, I think it would reveal that double hump sign, or that sine wave sign as it is popularly called. So a good clinical evaluation itself would guide you to the diagnosis. And all the other clinical features and parameters like a young female, typical history, hypermetropic, and most importantly tensions, the IOP is taken with an applanation tonometer. All those things together give you a strong clue.
Fine, thank you. So we'll move on to Dr. Ravi Kumar in the interest of time. Dr. Kumar Ravi, please.
In any case of ankylosing glaucoma, whenever we have a patent PI and we see that the pressure is not responding, it is a good idea to give a trial of pilocarpine. Plateau iris syndrome is one of the rare disease wherein pilocarpine is a drug of choice. Many times I have seen even after patent PI pressures of 40, 50, and the moment you give pilocarpine, by first dose or second dose, pressure comes down to below 20. So this can give an indication to general ophthalmologist that probably they are dealing with a case of plateau iris syndrome.
Absolutely.
Absolutely.
So in the interest of time, we'll move on to the next presenter because we are well past the time. So Dr. Shudipta, please, can you share your screen?
Yes, ma'am.
Yeah.
Is it visible?
No, it's not.
Not yet.
The sharing has started, but the screen is not yet visible.
Okay, just a moment.
Yeah, it's
yes. Yeah, now it's perfect. Yeah.
Now it's okay?
Yes, fine. Go ahead.
Okay, good afternoon, everybody, and thank you, KAO, for inviting me for this. So here is my history. A 68-year-old gentleman from Ranchi reported to our hospital for a full body checkup. He had pedal edema and he complained of off-and-on breathlessness and insomnia. His blood investigations revealed an uncontrolled diabetes mellitus along with high blood pressure and derailed kidney function test. He was referred to our department to rule out if he had any kind of retinopathy or not. So on ocular examination, his best corrected visual acuity was 6/6 and N6 in both eyes. Slit line examination was within normal limit. His intraocular pressure in the right eye was recorded as 20 by applanation tonometry and 22 in the left eye. Pupils were normal reaction and gonioscopies were also normal. On fundus examination, what we observed was he had asymmetric disc where CT ratio in the right eye was 0.6 and in the left eye was 0.5. He had healthy neuroretinal rims. There was no retinal non-fiber layer loss and there was no evidence of any kind of diabetic or hypertensive retinopathy. What prompted us to do a glaucoma workup was because of his asymmetric disc and his higher normal IOP recorded at that time. In pachymetry, the normal corneal thickness ranged from in the right eye was 540 micrometers, while in the left eye it was 555. His field test was also normal, and we took a disc photograph for documentation. A diurnal variation of IOP was advised in this patient in subsequent week, followed by a regular ophthalmology checkup for his systemic ailment. As you all know, the patient was lost to follow-up. He came back to our department after 6 to 7 years with the chief complaints of gradual progressive diminution of vision in both the eyes, often on redness and watering. The patient was disoriented, vague, tired looking, and had forgetfulness. The informer was his wife, and he had uncontrolled diabetes mellitus and hypertension, and he was suffering from chronic kidney disease, grade 4, on dialysis twice a week for the past 3 years. The patient was on multiple medication. He had no known allergies. He reported to his local ophthalmologist or optometrist to have a glass prescription changed once or twice, and due to deterioration in his physical health and mental health, somehow his eye checkup was missed. In his family history, nothing significant. Although diabetes ran in the family, there was no history of glaucoma. On ocular examination, what we could gather was his vision was in the right eye was 660, while in the left eye was 636. Intraocular pressure ranged from 18 mm mercury and 20 mm of mercury. Pupils, there was no sign of RPD. There was sluggish reaction, and there was no evidence of neovascular realization. Gonioscopy, what we observed that the angles were occludable, and it only opens on indentation. Anterior segment cataract changes were there, but not much, only in his grade 2. Now, the optic disc, what I saw was there was glaucomatous optic atrophy, almost cupped ratio of 0.8, similarly in the left eye. In the retina, there was no evidence of diabetic retinopathy or HDR. Maculas were normal, although the FR was dull, there was no CSME. Color Doppler was within normal limit. Field test could not be done because the patient was not oriented, and disc photography also could not be done since we could not dilate the patient and the media was hazy. So what was missed here? What was missed was case of depression, and he was on selective serotonin reuptake inhibitors, that is fluoxetine 20 mg for the past 4 years. Now, coming to the mechanism of these antidepressants, it has been reported to be associated with glaucoma, and it is hypothesized that it may increase the serotonergic effect on the ciliary body muscle, causing pupillary dilation. Now, the two theories that I have come up is, in the iris ciliary body complex, the presence of serotonin and its metabolites in aqueous humors plays an important role in the regulation of a reduction in the width of the iridocorneal angle induced by mydriasis may block the aqueous circulation, with the possible development of intermittent angle closure or intermittent angle closure or acute angle closure glaucoma. The next theory that was said was, in the course of chronic antidepressive treatment with SSRIs, multiple transient vasospasms at the level of optic nerve vessels may directly produce hemodynamic alterations that time to time could progressively induce a manifest optic ischemic neuropathy. So what are the points to ponder in this case? Systemic drug-induced glaucoma is a type of secondary glaucoma. The incidence of systemic drug-induced glaucoma remains uncertain till now. With an increase in the longevity of the patients are more dependent on multiple drugs. The various classes of antidepressant drugs are known to modulate glaucoma. Bilateral involvement and even blindness secondary to systemic drugs is reported in literature. And lastly, the treating physician as well as the ophthalmologist needs to be aware about the systemic drug-induced glaucoma in such patients. Thank you very much for your kind attention.
Thank you, Sudipta. We move on to Shuchandra with your discussion.
Thank you, KAO. Am I audible?
Yes, yes, clear.
Thank you, KAO. Thank you, Sudipta, for a great case presentation. But the only problem in this case, which I realized after talking to Dr. Sudipta, is that the patient was not able to perform a perimetry test, and because of his occludable angles, they could not document disc findings. So the vision was less, but we could not actually get a peripheral visual test done or to actually tell us whether it was entirely glaucoma which was leading to a visual compromise or whether there was some other factors peripherally also occurring because the patient had multiple comorbidities. But everything said and done, at this point, if we move on with the case of SSRI-induced glaucoma, there are seven types of 5-hydroxytryptamine or serotonin receptors which have been seen in the body, out of which 5-HT1, 2 and 7 are present in the eye along with their subsets. They are present in the cornea, iris, ciliary body, lens, and in the retina. Out of that, 5-HT subsets are present in the ICD or the iridociliary body complex. It has been seen that one stimulation of, now when we are using SSRI, we are reducing the uptake of serotonin. So we are increasing the serotonin levels in the aqueous humor and creating serotonergic agonism. Now when HT1 receptors are stimulated, there is a decrease in aqueous humor formation. But when HT2 and HT7 are stimulated, there is an increase in aqueous humor formation. But it has been seen that in majority patients, the ocular autoregulation brings about a stability in the IOP homeostasis and the IOP does not rise, other than few patients, elderly patients, where the outflow is compromised due to aging changes. The second thing that has been seen that HT7 receptors present in the iris sphincter muscles and they cause some mydriasis. So this can lead to a pupillary block, especially in patients where the angle is compromised, like in hyperopic, in those with teeth insertions, those with narrow entries, those with lens vaulting, etc. In this case, the patient had open angle 6 years ago, but probably developed a compromised angle because of intermittent pupillary blocks in this last 4 years that the patient has been on medication. But most reports say that the effects come into play within days or weeks after starting SSRI. Now, I have not faced any case of secondary glaucoma with SSRI so far. So I would like to ask the panelists, Dr. Thomas George and Dr. Niloy, is how do they treat such cases? Do they stop the drug, look back and then do a PI if necessary, or do they do a PI? Like in often we see that the angle reverses and we do not do a PI. Most of the cases we don't do a PI. So my question to the panelists, please.
Dr. Thomas George.
Thank you, ma'am. I will first, something hit me just now when I was listening to the presentation. I'll just say that one more thing that has happened here is the dialysis. During dialysis, they take out the solutes and actually make the blood hypotonic immediately post dialysis. It works exact opposite of us giving mannitol. So he might be having spikes because of that, worsening this situation, because especially because all the IOPs that Sudhita has got are not too high to cause such a progression. About the SSRIs causing closures, I've seen very few, though a lot of patients are on SSRI, but I have seen one or two, but nothing so dramatic. It's just angle becoming narrower and I need to do a PI. It is not precipitated acute closure, but these are patients I have good follow-up on.
Wonderful. That's a good possibility, actually. Yes, absolutely. So, Dr. Niloy, can we have your comment, please? Are you there?
Thank you.
Yeah.
Am I audible?
Yes, yes.
Okay. This is wonderful. I think it highlights two things. One is the need for taking medical history of drugs that we frequently miss in the outdoor procedures, especially history of these antidepressants and also antihistaminics and antispasmodics.
all these drugs can cause pupillary dilatation due to sympathomimic activity and angle closure. And so far as this anti-psychotics are concerned, probably Dr. Suchanda has asked whether we should stop the medicine or start the PI, do the PI. I think if the medicine cannot be stopped, we can do PI at this stage. And another thing is the need for doing routine gonioscopy. Once the angle is open in certain finding, doesn't mean that the angle will be open in the subsequent findings. So even if the angle is open in initial stages, we should continue or do routine gonioscopies at subsequent visits. These are my two takes.
In a disoriented patient, it's very difficult to convince them to go in for a laser therapy. In such cases, what would you do?
Yeah, we move on to Dr. Vanita to share her screen.
Hello.
Sorry, there was a question asked. You want to answer that, or shall I move on?
I think we'll do it after you finish the presentation.
Okay. Well, very good evening. Thank you for those still hanging around. It's been a long, sorry. Why is this happening? Can you see my screen? Yeah. Okay, fine. Sorry about that. Okay, well, I'm going to present, not in the conventional sense, a case report. I have got a group of cases all linked together with angle closure and bound by a common diagnostic. UBM seems to be the flavor, at least second half, which I could join whether these angle closure cases are unilateral, bilateral, or following LPI, whatever they are. I'll just take you through some of them. So the first case is a 72-year-old gentleman. I saw him only 2 weeks ago, where he had complicated cataract surgery and was left aphakic. Unfortunately, when he came to me, he came with a presumptive diagnosis of aqueous misdirection. He had vitreous and cortex in his AC. It was difficult, fundus was hazy. He was given mannitol, and looking at his AC, I thought this was not aqueous misdirection, because if you see, the central AC was deeper than the peripheral AC, and this is brought out very nicely in the UBM. As you can see here, you can also see what is blocking that pupil, and it is the vitreous in the AC which is blocking that pupil. So this actually became very simple for me. I went and did a PI, and you can see how deep the AC has become compared to pre-LPI. So that was the first case. The second case is now routine cataract surgery presenting with bilateral shallow AC. This is a little protracted case, so I'll try and shorten it as much as I can. 63-year-old lady, 9 days after left eye cataract surgery, she had high pressures and shallow AC both eyes. And as you can see here, a pseudoaphakic patient should not be that shallow. Gonioscopy was closed, she had sine wave sign. So obviously if PI has not been done, you think about primary angle closure, but of course plateau iris syndrome as well as aqueous misdirection is in the back of your mind, and that requires LPI to make a subsequent diagnosis. So obviously by ciliary process and absent iridociliary sulcus, and also both ACs were relatively shallow. So went ahead and did a YAG laser peripheral iridotomy, also a hyaloidectomy. And once that was done, I dilated the pupil and did a peripheral capsulectomy. You can see how deep the ACs suddenly became. And I thought this is it, but obviously the story did not end there. She did not, on gonioscopy, repeat gonioscopy, right eye was found to be completely open. Put on what I would have considered appropriate treatment and called her back in 2 weeks. But she came back in 3 days complaining of pain and blurred vision. And her left eye was shallow once again with high pressures. So in my mind now, the diagnosis was very clear that it was aqueous misdirection. Although I don't have a UBM at this stage, but you can see a plateau iris as well as aqueous misdirection or malignant glaucoma, as some people call it, have very similar features. Shallow AC or malignant glaucoma can also have flat AC with anteriorly rotated ciliary body together with absent iridociliary sulcus, seen here in yet another case. Are you not able to hear me?
Yes. It's coming in spurts.
Oh, I'm really sorry,
That's better. That's better.
Yeah. Okay, then the third one is a unilateral shallow AC, and this is now post laser peripheral iridotomy, uncontrolled on 3 drugs and vision fairly poor, count fingers. The left eye was deep, as you can see there. His pressure was uncontrolled in the right eye, and gonioscopy showed a posterior push mechanism. So differential here, uppermost in my mind was definitely lens-induced, although he vehemently denied trauma, but there are other things also that I had to keep in mind, and so a UBM was done as an idiosyncratic reaction. And unilateral angle closure is usually secondary. Actively seek the cause, and UBM is the investigation of choice in all such cases. Now I have, of course, videos of management of cases also, but then we are way past our time, so I shall stop. Bring you Independence Day greetings from my farmhouse where I am, where it has rained incessantly today, and I thank you for your attention. Thank you very much.
So you're in a lovely place, and we had a wonderful session, but I'll move on to Dr. Alokesh for the discussion. Your cases were fabulous, and Alokesh, could you just panelists for the final take-home messages?
Hello.
Dr. Alokesh, are you there?
Yeah, I'm there. Hello.
Yeah, we can hear you. Yeah.
Thank you, ma'am. Very nice collection of cases. But I would like to add just to your presentation specifically about your last case. We also had a case in which oral acetazolamide actually caused a uveal effusion syndrome with the bilateral precipitation of angle closure.
That's exactly what I said, yeah.
Yeah, that's what I'm saying. It was a topical in your case.
No, both.
Oh, both. It was right.
Yeah.
So I have experience of a case like that, and I think a previous question was being asked that, to my knowledge, in such cases, PI is not indicated. It is actually contraindicated.
Yeah.
You don't gain anything.
I actually in that particular case stopped everything.
Yes,
and
absolutely.
Only gave cycloplegics. Yes. And she regained her vision as well as normal IOP normalized within a week.
And the case in which there was a total anterior subluxation of the lens in the AC.
Yeah, I didn't get a reliable biometry. So what I did was with very minimal incisions. First stage I just took out the lens with an anterior vitrector. It wasn't very dense, the cataract, so I could take it out. Then I reassessed whether the patient would need a filtration. He did have 360-degree angle closure, and he did need escalated anti-glaucoma medication. So in that particular case, I did a Yamane technique of flanged SFIOL together with a superior trabeculectomy.
It would have been nice if we had time to see the video. And the other thing is, ma'am, when the cytophotocoagulation you were doing, ma'am, cytophotocoagulation, so you left the cyst alone and avoid it as far as possible. So it decreased the pressure presumably in the patient.
Just as photocoagulation transscleral would do. But unfortunately, transscleral, you don't know where you are putting, applying your power. Whereas here it was targeted, you visualized it, you avoided the cysts, definitely the thin-walled ones as you saw. And I just did about 2 quadrants, about 40, well actually 2.5 quadrants, 40 ciliary processes in her case, and it worked like magic.
Thank you. And at the post-op, was there any deepening of the AC? Because the cyst was not touched.
AC was not shallow. Her AC
Okay.
was the same as her right
Peripheral
eye,
AC?
but following, no, peripheral, it was still closed.
Okay, yeah.
360-degree, synically closed. And that is why, it was so useful to be able to achieve a dual purpose in doing the endocyclic photocoagulation.
Thank you, ma'am.
Dr. Prashant, can we have a take-home message from you?
Yes, ma'am. Wonderful presentation, ma'am. All the cases depicts clearly the great role of imaging device like UVM in documenting cases and knowing about the etiology of a typical glaucoma. I think nothing more to say. All the cases were managed so well, and it also cleared the message that UVM is such a wonderful device in knowing about the etiology of all the typical glaucoma.
I particularly wanted to talk about the first case where I could have easily done just an ASOCT to see the pupillary block, but I also needed to rule out that this was an aqueous menstruation. So I had to see the ciliary process behind as well. So UBM killed 2 birds with 1 stone.
Very nice case, ma'am.
Yes. Wonderful. On that note, can we go to the gallery, please? Mr. Jasprit? Yeah, can we go to the gallery?
Can I ask one question?
Yes, please. Yes, please.
Yes. Benita and Purvi is doing the UVM regularly, I hope, because in many cases, in the early post-operative phase, how do you do the UVM? If you think something is going wrong, will you go for the UVM or not? Early post-operative period.
The first case I showed you was 2 weeks post-op. You have to take all precautions. You just have to be, I regularly, when I use invasive techniques, I regularly use betadine 3 times along with paracaine before I actually touch the eye, whether I remove suture, whether I do a UBM. So it's all about how you adapt it in your practice. Yeah.
How early can you do it? How early you can do it?
I would do a gonioscopy 1 week if required, taking all precautions.
Would we?
Yeah, gonioscopy we do not earlier than 15 days, and UBM also, it again depends on how well the wound has healed. Like if you are sure that it's not likely to open up or cause problems with the pressure of the UBM cup or something, you can do it within 15 days or defer it till 3 weeks. But asepsis is a must. All said and done, whatever time you do, asepsis is very, very important.
Well, you cannot achieve asepsis in outpatients, but definitely antisepsis.
We'll try. You have to try for that.
Vanitha, can I add something?
Yeah.
Yes, please.
Yeah. Okay. UBM, the water bath and the wound stability with something leaking, I think that is what he's got a problem with. You got those, I don't know what they call them, those sandwich wrap like bubble that you can put on the UBM tip. They work pretty well and they come in sterile. They're expensive. Those I reserve for the wounds that I think are not too stable enough for UBM. But I would also do UBM at around 2 weeks. Gonioscopy, even on the very next day, I'm willing to do if the wound is stable. It's only a matter of will I disrupt it open? Because gonioscopy can be done almost practically sterile. You can sterilize the gonioscope with Dakins, etc.
Yeah, I would add with gonioscopy that I wouldn't do the 1, 2, or 3 mirror. I would, it's a 4 mirror, which is more gentle and gives you much more information.
Okay.
Yes.
Anything else? So on that note, then we go back to Rajesh. Rajesh, are you thinking of converting your subspecialty by now?
You need to unmute yourself.
Yes.
you know, as I told you before, my brain has a bit of a lag time. So I eventually managed to find the unmute button, and now I'm all there. It's very tempting, and especially looking at such glamorous people, I think being a cosmetic surgeon myself, I'm very tempted to change my stream, and so that some of the glamour rubs off to me as well. But you know, on this note, today is a special day. It's a 74th Independence Day for the country, and it's been made really special for all of us at the Kolkata Academy of Ophthalmology Bio erudite speakers and panelists. All of you have been truly inspiring, and we thank you from the core of our heart. I thank Dr. Shurajit Chakraborty, Dr. Chandrima Paul, Dr. Shumit Chaudhary, and all the EC members for their hard work for making this program so grand. I sincerely thank Sun Farmers Avesta Division for the logistical help. And last but not the least, it will be really amiss not to give a big thank you to the technical support team led by Mrs. Sujata, Mr. Jaspreet, and Mr. Rohit. I thank you all. It was a great beginning, and I hope we can do this again next week and week after that. And all the panelists and faculty, I invite you to join our program again for the following 2 weeks. Thank you again.
Thank you.
Thank you. Thank you very much. There are a lot of
Good night,
questions,
everybody.
but we couldn't take them, unfortunately. But thank you very much. Yeah. Thank you.
Thank you so much, everybody.
Great.
Thank you. See you again.
Congratulations.
Thank you, ma'am. Thank you, sir.
Thank you.
Thank you.